Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy 20 webinar on the topic Obstetric Ultrasound Simplified. Before going for the webinar, we will have a small prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal Obstetric and Gynecological Society. She is Founder-President of ISOVAP Chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary cum Joint Treasurer of MPIAG. She is Coordinator of FOXI Infertility Committee. She is also the convener of this Synergy webinar series, as well as she was the convener of Perfection series and Symbiosis series. Over to Dr. Monica Singh.
Thank you. Thank you so much, Vishal. Thank you, all dignitaries, for joining us today on this beautiful evening of October when festivities of Diwali are in the air. Dr. Madhuri ma'am is catching a flight tomorrow to Kenya. She just came back from Cape Town. And I think everyone is so busy at home and in workplace that it is a wonder that we have got such a galaxy today. It is almost like the Diwali sky is, lit up with fireworks. I've got that feeling of excitement today. So today we are very, very honored that we are doing the Synergy Club 20th webinar on obstetric ultrasound simplified. This is a topic of which nobody can get enough. Any amount of obstetric ultrasound we do or we learn or we watch, we always the dil mange more. So this webinar is in association with two very dear societies, Chandrapur from Maharashtra and Faridabad from Haryana. And we are privileged to have amongst us as chief guest Dr. Madhuri Patel ma'am. So I will start by honoring and welcoming our chief guests, followed by our esteemed guests of honor, Dr. Rosa Oliai ma'am and Dr. K.S. Jairani Kamraj. We will also felicitate our special guests for the evening, Dr. Monica Umbardant and Dr. Priya Gupta, who have done us proud by, becoming beacons of Foxy in the, last election. And my co-convener, I'm thankful to Dr. Randhir. I'm really thankful to my program coordinators, Purva, Nandini, and of course, we pay our respect and gratitude to President and Secretary of Chandrapur OBGY Society and Faridabad OBGY Society. In this program, we are going to predictably so going to advance from the first trimester of pregnancy, which is being taken by me, followed by the much awaited second trimester ultrasound, which will be taken, the talk will be taken by Dr. Sujit Kodkar, and the third trimester ultrasound, the heaviest and the most awaited talk would be by Dr. Bela Bhatt madam. So this is a short walk through our program. And now, without further ado, we come to the most pleasurable duty of introducing our favorite and our most dear Dr. Madhuri Patel ma'am, who is President Foxy 2027. A big congratulations to Madam for having contested one of the toughest elections of medical professionals in India, and I think all over the world. There is never an election like this, the presidential election, where I think everything is at stake. So much of energy, so much of sweat, blood, toil, hard work, emotional, physical, mental upheavals. And then there is one star which shines amongst all the candidates who are absolutely awesome. So, Madhuri ma'am, we are so grateful to be having here. We have seen your hard work in Foxy. We have seen you on that stage. In fact, that stage of Foxy, every time we think of the Foxy stage and the managing committee meetings, any AICOG, valedictory or inauguration, the picture comes to our mind of your, always busy with work. I think Madam is the only Secretary General. Her close friends have vouched that Madam has not slept for even 2 hours a night last 3 to 4 years, if I'm not wrong, Madam. And still next morning she is there with, just double and triple energy to go on. There is no, work she has not done. And along with that, she has, taken Jogi the journal of OBGY in India to another level. She is the one who motivates everyone. Every time she's scolding me, Monica, you have not applied for, peer reviewer of Jogi. And I always am lagging behind in my work. But she's the one who says, Monica, you should go, you should apply. And she's telling me, when my Foxy application went for the chairperson election, she was the one who pointed out, Monica, there is some, mistake you have made. Please correct it. So I can never forget you, madam. I can never forget your kindness to all of us, especially to me. Your appreciation award all over the India from Foxy, from ICOG is just a testimony to the great work you have done over the years. You have devoted whole life to Foxy. You have sacrificed your own pleasure and family to for Foxy, ma'am. And we are so grateful to you, ma'am.
Monica, thank you so much for your kind and, I will not say, encouraging, but I'll say kind and such a warm welcome and talking about me. And, this everybody speaks. I'm aware about it. And I'm really proud that I gave a soul to my Foxy. And today, you all have elected me as a president, Foxy 2027. So I'm really, really owed to all of you. So let us come back to our, program that today's guest of honor are Dr. Rosa Olai. She is very, very good friend of mine since last 2 decades, and we have worked together in Foxy when she was vice president and the adolescent committee chair. And she has also worked in FIGO. Her work is always admired by everybody. And of course, Dr. Jayarani, I must say, another good friend of mine, how much work she has put up for her, career as well as the Foxy. And as a president of, Chennai, Southern India Society, she has worked very hard and now she has become chairperson. So I really congratulate her for her hard work. And of course, today's, special guest, Monica. She's another hardworking, and Priya also very, very hardworking. I congratulate both of them for becoming the committee chair. And when everybody goes through the election, they know how much hard work we have to put. Of course, Bella is going to be, she is not going to be, she is my vice president for my, year. And I'm hoping that she will come out best vice president. Of course, all my vice president are best, but you will be doing most of the work, I think, especially in fetal medicine and sonography, which is very close to your heart. And I congratulate her also. And of course, Sujit is there. She is again, elected. He is also, he's very quiet like me, But now I'm talking a lot, but he is a silent worker. And, I again congratulate to him for the same. And of course, we have our, convener, Dr. Monica Singh and Dr. Randeep. They were solid support like you for me every time during my election. And one of the advisories people, they had worked for me. So I'm really thankful to Monica. And Monica, I'm wishing you best that you should join Foxy official position as early as possible. And I'm wishing all the success for you. Then, of course, the Faridabad Society, Dr. Kiran, Dr. Chanchal, then our Chandrapur Society, Dr. Kalpana and Dr. Narucha, and of course your co-coordinator, Purva and Nandini, and other, chairperson, and Dr. Vishal is here, and all my delegates friends for joining here, and good evening to all of you. I would like to express my heartfelt gratitude to the organizer, especially Monica and Navdeep, for honoring me as a chief guest for the important webinar on ultrasonography, obstetric ultrasonography simplified. If you look at the sonography, in the past, when the women were not educated, in the third trimester, they used to register. But now there is a change of pyramid, and now all the women are educated, so they do come to us as soon as they miss the period in the early conception. And Monica, no other than who will talk best about first trimester sonography, early dating, vesicular mole, ectopic pregnancy, missed abortion, blighted ovum, prediction of PIH, IUGR, and of course, invasive procedure. Monica is going to speak lots about it. Second trimester, of course, Sujit is going to talk about the malformation, including 2D echo, and Bela is going to talk in the third trimester, especially fetal growth retardation, and other factors like placenta accreta syndrome, and certain invasive procedure, in those type. Third trimester, I'm talking. Second trimester, we all do amniocentesis when we have abnormality in a dual marker or quadruple marker with the malformation. But in third trimester, Bela is going to justify her topic. And both of them are going to speak for 2 hours. Okay. So I'm really, thinking how much you are going to cover the whole obstetrics. And Monica, half an hour. I think next time Monica will also speak for 1 hour. So, we are covering entire obstetric by ultrasonography simplified. And we are going to learn a lot. And chairperson are also excellent. So with these topics, we are going to learn something and we are going to implement in day-to-day practice, which will help our women and the babies. And, I would definitely congratulate, Monica, Ranveer, and entire team for this, one of the best webinar which we are going to have it. And I wish them best luck for the same. And of course, as I mentioned earlier, that I again thank you for electing me with a thumping majority of 2,200 votes for electing me as a President Foxy 2027. This milestone in my journey is not only the personal achievement, it is a support, unwavering support I received from you and trust put by you in me. This trust is profound honor to me and will work hand to hand, holding hand to hand with each other during my Foxy presidential year 2027 for the advancement of the women's health will make it memorable. You all are working together, going to work together with me. One of the, many people say, Madhuri, before election, Madhuri, when you become president, we all are going to be president. So I keep my words during my year and we all are going to work together for the same. And at the end, I would like to always mention about the quote of Nelson Mandela. Education is the best weapon when used can change the world. So dear friends, let us use this education, update ourselves and, give the best to a woman. Thank you once again for giving me this opportunity.
Thank you so much.
Dr. Madhuri, since you've come back from FIGO, what is a good result of president's election?
Today, it is going to happen today.
Oh,
They are 4.5 hours away from us.
okay.
So it was going to start at 3 o'clock. So we'll get the result today.
Okay, just let
In
us
few
know.
hours. In few hours.
Few hours time. Great. Thank you. Thank you. Lovely.
I think India is shining everywhere, Rosa ma'am. So India should shine in FIGO also.
We want
Yes.
Madhuri to shine in FIGO as well one day.
Yeah. Not now. Now at present, Foxy. Just Foxy.
Yeah.
So thank you so much, Madhuri ma'am, for those very, very kind and generous words for the entire program. As a president should be speaking, you have spoken so. So, ma'am, thank you for being there. And now I take the extreme privilege and honor of introducing our guests of honor for the evening, Dr. Rosa Oliai, ma'am, a mentor and a senior who is very, very close to me, to my heart. She is the immediate past president of Gwalior OBGYN Society, a very looked upon senior and mentor in the state of Madhya Pradesh, and the state coordinator for Foxy Aduna project. Can I have Madam CV, please? Madam has been in the forefront of OBGY, not only in MP, but because she was the first person who took forward the state to the national level. She is at present director of Oliai Hospital in Gwalior, MP, a historical city. She has been selected as the state coordinator for Foxy Aduna, Bill Gates Foundation Project 24 to 26. And as I came to know from news, FIGO is also having a session of Aduna, which was held yesterday. She is the member of Medical Advisory Panel for Family Planning Association of India, has held the post of the president of the very vibrant GOGS, chairperson SPC MP, member of National Screening Committee of FPI, representative board of trustees of HACCP South Asia, member and member board of governing council of ICOG, vice president of Foxy way back in 2014. She's very fond of adolescent health, and she has chaired the Adolescent Health Committee, which was, I think, the prize-winning committee of 2012. She has been the FIGO representative at the WHO session of FIGO World Congress Rome 2012 and a WHO consultant in the expert panel meet for making global guidelines in adolescent and sexual reproductive health, Geneva. As I was speaking, by Rosa ma'am, you were on the phone that you are very, very passionate towards adolescent health, and your committee won the best committee prize. Madam
Thank
has
you.
been awarded the prestigious Dr. DC Datta Prize, Dr. Mehru Dara Hansotia Prize, and has over 100 peer-reviewed publications in index journals and has authored 4 textbooks, co-authored 8 books in OBGY. Welcome, madam, and we are so honored to have you. We'd love to have blessings
Thank you.
from you,
Thank
ma'am.
you so much, Monica. I was on an emergency call. To be present in your meeting is always a privilege for me. At the outset, I really want to congratulate first Dr. Madhuri, my very dear friend. So proud of you and so happy that a woman president is going to be there for us. She has worked a lot, and just to win the election is nothing, but her work speaks in itself. So proud of you and so happy to be a good friend of you. We started work in Foxy together, and I'm looking forward, as I said, to see you sometime in FIGO very soon. Now, regarding the program, and my dear Monica and your, I should say, I don't know which half, Randir, who had been doing this program. And I think today is the 20th episode, I was told, of your webinars. You are into so many webinars, and I'm so happy to be always with you in most of your webinars. So keep up the good work. And it's always so good. I feel so good that when husbands and wives work together and support each other in all the activities. And the way you are, Monica, as a lovely person by heart, the way you speak, the way you keep your relationship, and the way you go forward, I just wish you all the best for your upcoming elections next year for the Infertility Committee. I think you should start talking about your committee now. And of course, with me, I'm so happy to share the bench with my dear friend Jaya Rani, who once I attended, I think a few weeks back, your webinar on sexual health. I think one of the very good webinars that, you had called an international webinar together. Keep up the good work in the committee that you're in, Violence Against Women. A lot of scope to work in all aspects from adolescent to menopause. At the same time, I'm quite familiar with Monica. So many webinars which you have attended. Priya, congratulations to both of you. So happy to see the hard work pays on. Coming to Sujit, also congratulations. I hope you keep up the good work that you are doing. And of course, I don't want to miss out on my very dear Bella. Congratulations to you. You did work very hard. And I think the first webinar that you had for your campaign was Gwalior, Madhya Pradesh. So all the best to you in your future endeavors. And at the same time, Dr. Vishal, you are here. Nice to meet you, and great to know that you're working with Monica, and I'm sure doing this work will go in a greater way in futures as well. I do want to miss out on Purva and Nandini, who are with you. You said your right and left hands, walking sticks. It's always good to work in a team. And I'm so happy, Purva, you're here. I can see your picture live. The other windows are closed. I don't know who else is here. But I think a teamwork is always the best that works. Dr. Madhuri has explained the webinar in a very beautiful way. I will not repeat the names that she has repeated because she beautifully, so well she described everybody, the chairpersons and the other speakers. All I want to share with you all, dear friends, is always a teamwork works. Be with your like-minded friends. Start having webinars, which is very much what like today is. Point, very much focused, and what is really practical. And you've got, Monica, the best of speakers with you in this. things have changed now. The pyramid is changed. We have to think about modalities, media, ultrasonography. One thing which can help us in many diagnoses and preventing complications, especially, I'm sure the speakers will throw light upon placenta and the position of placenta. So many things. I've got an emergency actually. The phone is ringing. So I would like to cut down here. Don't want to waste your time. And I think there are a lot of good things in this webinar to go ahead. Wish you all the best. And I look forward to see more webinars of this kind. Thank you so much for inviting me.
Thank you. Thank you so much, Rosa ma'am, for the kind words, and hope you can join us again after attending to your case. So now I take great pleasure in introducing our guest of honor, Dr. K.S. Jairani Kamraj ma'am. Madam is again a very close and dear mentor to me, a great senior, almost like family. And whenever we meet each other, it is always she has a good word, a good advice for me. I have seen the hard work and the passion with which she has worked, her deep interest in the sexual health of women, and which has made her, well known all over the world as the advisory council member in the World Association for Sexual Health, the first from India to have that post. Madam has also been the immediate past president of OBGY Societies of Southern India, vice president of TAPISAR, joint secretary of TN4, has helped organize ISAR 2015, a joint organizing secretary, a faculty member of Dr. MGR Medical University, lifetime member of FOXY, lifetime member of SRM and ESHRE, with several medals and awards to her credit. Best Doctor Award by MGR Medical University, Rajamani Jankiraman University First Prize Award, and many, many others. I think, Madam, I'll give the stage to you to speak to us because we want to listen to our guest of honor and we want to know a little about your journey into FOXY.
Thank you, Monica and Randi. And a very special, I'm truly honored, Monica. A very special thanks to you because you have given me a platform to be a guest of honor with a great presence like Madhuri Madam and Rosa Madam, who I admire and wonder. And it gives me a great pleasure and honor and privilege. And I'm really having a gratitude to you to give me this guest of honor. And I'm really touched with your thing, and I'm really emotional to share this platform with the doins of Madam and Rosa Madam. So thank you for that wonderful introduction, and thank you. And we know pretty well that today you have chosen this ultrasound, which is almost, we think it is a stethoscope for life before birth, because earlier we had many tools which are not that much well applied for the clinical practice, especially in the obstetric practice. But today we have a very great one, that is an ultrasound, which is like a stethoscope for life before birth. We always, which allows us to see, understand, and see what is happening, and so that we can have a better protection both for the mother as well as for the child. So in that way, the ultrasound plays a key role in obstetrician's clinical practice to help us to identify the complications and protect the mother and the child in the best way. As pointed out by Madam Madhuri Madam and Rosa Madam, yes, it has become a very good clinical tool for us to give a safe maternity care. And you have given a very nice topics right from the early confirmation. Of course, we know pretty well the women's journey in her pregnancy involves so many risk factors right from the first trimester to the last trimester. And you have given very beautifully the senior speakers here who will be talking on the early pregnancy, that is you, bringing out all the good and the intrinsic things and the complications, what we see, that will give us a good tool to identify many things right from the first trimester and see how the growth profiles in the middle trimester. And also a very great person like Bella will be talking on the last trimester to give us a good input about the safety of the mother and the maternal childbirth. Everything comes in a proper comprehensive way, and as you rightly pointed out, you made this obstetric ultrasound so simplified with all the great three people to talk about everything, so that anyone who listens to it will just be grasping most of the information and knowledge about ultrasound. I really appreciate you for making this knowledge packed one in a good way, And I really congratulate you for making this wonderful webinar. And though we know that there are a lot of improvements in the technologies like 3D, 4D, everything has come, but still a precise, proper ultrasound by the obstetrician is a good tool to give the safety for both the mother, and that is very important. And anytime we also has to think the ethical way. So though the technology has been improving and increasing, but we should always have the ethical responsibility in handling the ultrasound. That also we must inculcate into the youngsters who are coming up and taking up an ultrasound. And definitely every image of the ultrasound carries an emotional way, what we connect to the fetus. That's very important, because we are the first one to see the heartbeat, especially as a fertility specialist. Every heartbeat, every growth scan always gives us a happiness of so much enjoyment what we are bringing to the couple, to the family, and we all owe that as an obstetrician. So in that way, what you've taken this ultrasound is really very close to my heart, and I really loved all the topics what you've kept. It is really a science with emotion. That's what I always feel about the ultrasound. So definitely whatever you have taken is topics are very good, and all the speakers in this are they'll be doing definitely a great justice. And I'm very thankful for you to have this webinar in such a nice way. And only one thing that we have to know in India, it's definitely the ultrasound makes a lot of impact. Just like our Foxy has made an impact on the maternal, bringing down the MMR. Ultrasound also has an important role in playing to reduce the maternal mortality and perinatal and the fetal morbidity. In that way, I really congratulate you for bringing out this nice topics. And I'm really once again thankful for getting me into this platform with great persons like Madhuri Madam and Rosa Madam. I really owe a lot to you. And I'm very special thanks to Faridabad presidents and the secretaries of Chandrapur, who are all gave me a great support in my elections. And I know we all had a lot of talks and other things before the elections, during the elections. And I'm really thankful to all the presidents and secretary, and a very special thanks to Monica and even Priya for all working together in the nicest way during the elections. It is one of the memorable ways that though the elections give you a lot of stress, but it is also good to connect with everyone, which gives you more of a Foxy friendship under the field. So that is always, I feel, very emotionally. Thank you so much. Madam Madhuri Madam, thank you so much for your wishes and kind words. And Rosa Madam, thank you so much for your inspiration. I'll definitely make an impact of what is your expectation, and definitely I'll get a good remarks from you at the end of my session with Madam and you. Thank you so much. And thank you, Monica. Wish you a very good luck for this webinar, and also very good luck for your future endeavor in Foxy. And I'm really, definitely you will make a real change and real good impact in Foxy's infertility committee. Thank you for inviting me, and over to you, Monica. Thank you.
Thank you. Thank you so much, Jarani ma'am, for mentioning so many nice things about the webinar, about each and every person present here. And now I invite our special guests. Special guests are people who are special in some way. So are Monica and Priya. We congratulate jointly Monica Umbartant as Chairperson-elect Public Awareness Committee of Foxy, and Priya Gupta, Chairperson-elect Family Welfare Committee of Foxy. They put their heart and soul in the elections. I will not read the slide. I would just like to say, if there's anything in Foxy, any information I need about any person, I just message Monica. And next morning it is there. So she is my go-to person. Thank you so much, Monica. And thank you so much, Priya. You've always been great friends, and I know how much hard work you'll put into your committees, and you'll definitely be an asset to the organization. So I would like to have a few words from you. Monica, you first, then Priya.
Thank you, Monica ma'am, for inviting both of us jointly to this webinar, because this will be the first webinar after the elections. And it is an honor to share the stage with stalwarts of Foxy, with Dr. Madhuri Patel Madam, Dr. Rosa ma'am, and Dr. Jiyarani Madam, Dr. Bela Bhatt, of course, Dr. Sujit, Dr. Priya, and with the Chandrapur and Faridabad societies. Both the presidents, Dr. Kalpana Madam and Dr. Kiran Chandana Madam, have been really, really very helpful for the entire election process. There has been not a single day that I have spoken to Kalpana Madam for anything, and she said no to me, ma'am. And that holds for even Kiran Chandana Madam when something from Punjab and Haryana, Madam has always been there. So both of them have really, really helped me also. So it is an honor to share this space with all of you, and I am really obliged with the comments that Madhuri Madam, Jayarani Madam, and Rosa Madam has spoken about me and Dr. Priya. So we wish you all the very best, ma'am, for all your future endeavors in Foxy. And I'm sure your hard work from the last 6 years, I have been seeing you consistently doing it. And this is the 20th episode of the Synergy webinar series. And you've chosen rightly the topic of ultrasound, which is really very close to all obstetricians, but most of us do not have the basic training. And that is why all of us either send our patients to do an NT scan or an anomaly scan, just for the sake of sharing the responsibility of medical legal aspect. That is what I wanted to highlight. कि एक स्कैन बाहर करा दिया तो थोड़ा सा responsibility share हो जाता है. So you have taken topics in such a way that each obstetrician will be confident in giving the report themselves, and it will be more reassuring to the patient that the caregiver herself or himself is doing the scan, because that is the most assuring thing to the mother to be that the baby is in safe hands. So this definitely will go in a long way to reduce the stress of the mother and the perinatal mortality, morbidity, as what Jayani Madam has rightly said. So thank you so much, ma'am, and wish you all the best.
Thank you. Thank you so much, Monica, and wish you all the best as well. And Priya, we would like to have a few words from you.
Yeah, madam. First of all, good evening, everyone. And I'm really grateful to be invited for this esteemed honor to be the special guest for today's evening and webinar, and sharing the platform with none other than our President-elect, Dr. Madhuri Patel, madam. First of all, I would like to express my heartfelt gratitude to each one of you for supporting my journey into the Foxy. I was just working with a committee, and it was really heartfelt, having blessings, having kind words, having words of motivation from each one of you to getting me this platform and make me the this chairperson elect for the upcoming year. So thank you so much. And I would really like to pay my sincere gratitude to Madhuri Madam, Rosa Madam. Like to congratulate Jairani Madam. I've been bothering her since quite a long time. Dr. Sujit Sir, then Dr. Bela Bhatt Madam, you all, and Dr. Monica, and all the respected president and secretaries present over here. I think you all have been a great support and a big, big motivation in all the journey throughout. And as far as Monica Madam has been concerned, I've been in connect with Madam. I think it's quite some time, maybe 4 years. I've been knowing her really generously, and she's a generous person. And I'm really grateful, Madam, for this kind honor to making me the special guest for today's evening in this webinar. As far as the ultrasound in obstetrics is concerned, ultrasound has always been my passion. But due to certain limitations in my working, I've abandoned doing ultrasound, but my passion is still continued. And I really feel that ultrasound has transformed the landscape of the maternal and fetal child care, which we are offering in our day-to-day practice. So it's the basic necessity to know about the basic insights of the ultrasound, how it is important in evaluation. And as all our esteemed seniors have said, it is definitely a very important tool, and that too non-invasive, in reducing the maternal and fetal mortality as well as morbidity. So I'm really looking forward to hear the talk from all of the experts today, and I wish you all the success in your future endeavors, madam. Thank you so much for inviting me.
Thank you. Thank you, Priya, for the very generous words. And we love having you in the program, as always. Now, I would like to welcome our President and Secretary of Faridabad OBGY Society and Chandrapur OBGY Society. I can see Kiran Chandna, Madam. Madam, would you like to, Kalpana Ma'am is there?
Yes, ma'am. Kalpana, ma'am.
Yeah. So we begin with Chandrapur OBGY Society. And Kalpana Madam is there. Dr. Kalpana Gulwade is the President, Chandrapur OBGY Society. We welcome Madam and we extend a heartiest thanks for giving us an opportunity to collaborate with Chandrapur OBGY Society. Madam is the current President of COGS. She is working at Gulwade Hospital in Chandrapur. She has done some wonderful conferences, AMOGs of 2025, organizing secretary in Chandrapur, as well as the advisory member of the district PCPNDT committee, secretary IMA, best secretary state and national IMA, and has held various posts in Chandrapur OBGY Society. She has been a finisher of Ironman. That is something very, very awesome, Kalpana ma'am, and a marathoner. Her special interest is endoscopic, gynec endoscopy, and obstetric ultrasound. So she'll be an asset to the program today. With so many extracurricular activities she participates in. Kalpana ma'am, we would like to have a few words of blessings from you, please.
I will not keep everybody waiting. Thank you so much, Monica, for having me here. And all the best. This is a lovely initiative. We are all waiting to hear the speakers. Thank you so much.
Thank you, Kalpana ma'am. Thank you. And we would love to have some fitness from you also at the end of the webinar. So now,
Yes, sure.
Dr. Rucha is there, Purva?
No, ma'am. Dr. Rucha is not there.
Okay, we will wait for her to join. And from Faridabad, we have President Dr. Kiran Chandna, Madam. Madam, it is my extreme honor and privilege to welcome Faridabad OBGY Society to collaborate with Synergy Webinar Series. Madam is the Director of Chandna Medical Center, Faridabad, President of Faridabad OBGY Society, has held various important significant posts in Faridabad as Menopause Society as well as the Haryana OBGYN societies. She has been the key person behind MTPCon 2022. She has been the organizing chair of Cadaveric Dissection of Internal Iliac Artery Workshop in 23, awardee of Surakshit Nari Unnat Bharat Award, faculty in various conferences, a keen academician, and we are thoroughly overjoyed to have you with us, Kiran ma'am, today. Kindly address us with your loving words.
Thank you, Dr. Monica, for involving our society for this webinar. I wish you all the best and my great sincere namaskar to everyone present here, and I wish you all the best. And now we will listen to the academicians, our speakers. Thank you so much.
Thank you, Kiran ma'am. Thank you.
Thank you so much.
And I must again say that the friendship between me and Kiran ma'am goes back a lot many years, and every time she has been very, very loving and supporting. Is Dr. Chanchal Gupta with us, Purva? Okay. Right, we will wait for her to come. And before we start our scientific session, I would like to acknowledge the support of my two beautiful girls, Purva Pathur and Nandini Singh Bhati, who are assistant professors in GMC. I think they are on the way to become associate, almost done. So, and they are very good teachers, very good surgeons, everything, but they do their work so dedicatedly for me that I feel that I must be the luckiest person in the world. So thank you, Purva. Thank you, Nandini. And I would also like to thank my co-convener, Dr. Randir Singh. And before we start, I would just like to have two words from our speaker. Congratulations to Sujit Konkar for winning the chairperson election of Foxy, getting the committee he's very close to. And of course, our dear Bela Bhatt madam for winning the very closely contested VP elections. So Dr. Sujit and Dr. Bela, ma'am, would you like to speak to us before we start?
Yeah, only one sentence I would like to speak here. Best wishes to you for next Foxy elections, because I'm going to talk for 45 minutes after you, so I won't take much time. Thank you.
Thank you, Dr. Sujit. And that is short and sweet. And I must say that Dr. Sujit, from what I have followed him in the Facebook, he's a very keen cricketer as well as a music aficionado, right? So he loves the music, and I think he sings also. So welcome on board, Dr. Sujit, and welcome Bela ma'am. And now I think we hand over the first session to Purva to begin the academics.
Thank you so much, ma'am. So moving to our first session, that is on first trimester ultrasound in early pregnancy. We would like to invite Dr. Manisha Vasade madam, Dr. Dipali Mittal madam, Dr. Rucha Pode madam. Dr. Manisha Vasade madam is stuck in some emergency, ma'am. She will be joining us shortly. Next, we have Dr. Dipali Mittal madam. Madam is presently consultant at Apollo Hospital, Indore. She was past joint treasurer and joint secretary of Indore OBGY Society and is a keen academician. We welcome you, ma'am, to chair the session. Next, we have Dr. Rucha Pode madam. Madam will be joining us shortly. Now, I hand over the session to our chairperson to introduce our speaker, Dr. Monica Singh, ma'am.
I think Dipali is not there. Purva, you
Yes,
can...
ma'am, she's there.
Yeah,
Dipali.
Dipali is there. Right. Hi, Dipali. Hi.
Hi, ma'am. Good evening, everyone. And actually, at the outset, I'd like to thank Monica, ma'am, because of her, I'm able to, share the dais with all the doyens of the Foxy, and it is really a proud privilege for me. Good evening, everyone, once again. And actually, Monica, ma'am, doesn't need any formal introduction because this is her show only. So उनके लिए कुछ बोलना था, it's like सूरज के आगे दिया दिखाने types है. Then I must say she's not only a distinguished gynecologist and infertility specialist, but also a very remarkably humble and approachable person. So ma'am, for real actually.
Thank you. Thank you so much, Dipali. Thank you for the very short and the sweetest introduction. So with now permission of the chairs, I'll start sharing my screen and just give me a minute. So is my screen visible?
Yes, ma'am, your screen is visible, but your voice is echoing, ma'am.
So I'll just...
Monica, you're connected with some nearby another connections. Two connections, if you have, you may have this. The echoing because you have two connections adjacent. Probably that's the reason.
Yes, ma'am, it's still there. Ma'am, are two devices connected?
No. I'll leave. What about now?
Now it's fine, ma'am.
Now it's okay. It's okay, Monica, now.
Yeah, yes, ma'am. So I don't know what happened, but Sujit, can you start with your first talk? I have some problem, some glitch. Sujit is there?
Yes, ma'am.
Dr. Sujit?
Yeah, sure.
Yeah, you take the first talk. Till then I'll sort it out, Some problem with sharing the screen. Apologies.
So, Dr. Nandini, are you there?
No, let Dr. Sujit start the talk. The chairpersons can shift to the second session.
Okay.
Right. Yeah. Dr. Sujit, he has to introduce. Yeah. Just talk about Dr. Sujit. Yeah.
Dipali ma'am, will you be comfortable in introducing, or should I?
No, Dr. Anju is there. Dr. Anju Verma is there. She can introduce Sujit.
Dr. Anju Verma.
Yeah.
Monica ma'am, you need to unshare your screen first so that I can share my screen.
No, I have not.
Sir, actually the CV deck is shared.
Okay.
Yes.
So is Dr. Anju Verma there for the second session?
Yes, ma'am, she's there.
Dr. Anju, are you there? I don't think she's there. So, Dr. Dipali, can you introduce Dr. Sujit, please?
Welcome, Dr. Sujit. He is fetal medicine consultant, and he has done his MD Obs Gynae from GMC Aurangabad. And he has his US sonography training center by the name of Dr. Bimal Sahani Aurangabad. And he's trained in basic invasive procedure training at Dr. Khurana sir's and Dr. Khurana sir's Apex Institute. And he is FMF certified from 11 to 13 week scan, preeclampsia screening, Doppler ultrasound, and fetal abnormalities. He is the chairperson elect Genetic and Fetal Medicine Committee FOXI 2628. He is Vice President Society of Fetal Medicine Marathwada Chapter, past chairperson Fetal Medicine Committee AMARS, Director Shri Hospital FOXI recognized, which is the FOXI recognized USG training center. He is interested in advanced fetal ultrasound and fetal interventions, and has special interest in singing and cricket. So I invite Dr. Sujit for his talk.
Big thanks, Dipali ma'am, for kind introduction. I'm going to share my screen now. Is it visible now?
Yes, sir.
Yes, sir.
Just so good evening, seniors, my friends and colleagues. At the outset, I would like to thank Monica ma'am and Ranveer sir for giving me this opportunity. So my topic is second trimester ultrasonography screening. This is a very, very basic topic, and we go by guidelines. So all the ISWA guidelines are taken into this. So before taking probe into your hand, before touching the patient in second trimester scan, you should know everything about the patient. So history is very, very important. You should have basic history, name of the patient, age, obstetric history in the terms of GP, LA, gravida, parity, living and abortions, LMP, exact LMP, whether there is any previous scan was done and whether it is corrected or not. These are very basic things. Then post obstetric history. Is there any history of any anomalous baby, recurrence, pregnancy loss, preterm delivery, fetal growth restriction, preeclampsia, or is there any history of previous cesarean section? Complete family and genetic history. History of consanguinity is very, very important to know the carrier state of the babies. History of genetic diseases in family, Is there any history of intellectual disability or any known carrier status in parents, and general medical and surgical history we all take regarding diabetes mellitus, hypertension, any renal problem, cardiac disease or surgeries in the past, or any allergy to any medications. And next is quick survey. Before going into detail, we move the probe up and down and transversely over the abdomen so that we have an idea whether the pregnancy is singleton, amount of Leica, any position of placenta or any obvious anomaly. We come to know that, and then we start for the detailed scan. So as I have stated earlier, we go by guidelines, and my talk is based on these ISWA guidelines, which are updated in 2022, performance of the routine mid-trimester fetal ultrasound scan. And this is a very basic talk. So the routine mid-trimester ultrasound scan includes an evaluation of the following things. Number one is cardiac activity. This is the basic thing in ultrasonography. In each trimester, whenever you pick the probe, you look at the cardiac activity. Fetal number. If the patient is coming to you for the first time in second trimester, yes, you have to look at whether the patient the pregnancy is singleton or multiple, and then again look at the chorionicity and immunogenicity in cases of multiple pregnancies. Then look at the gestational age and fetal size. Gestational age is different, fetal size is different. Dating in second trimester is a very good topic and very different topic. I will come to that. And fetal size, will give you about the estimated fetal weight, and that will help you in various disorders of growth. The basic fetal anatomy is the cornerstone of second trimester anomaly scan. Placental appearance on location. Again, this is very, very important. A rough estimate of amniotic fluid volume in second trimester. And in some settings, measurement of cervical length is also necessarily taken in this case. So basic thing in mid-trimester, second trimester anomaly scan is structural survey. Anomaly scan, this mid-trimester anomaly scan after 16 weeks is also done for second trimester aneuploidy screening to look for the markers. But that is another big topic, different topic. This is not included in this talk. So coming to fetal biometry and well-being. If we talk of biometry is available for each and everything in the fetus, in fetal medicine. But the basic biometrical things we follow are biparietal diameter, head circumference, abdominal circumference, and femur length. These are the four basic things, and everything in fetal growth, estimated fetal weight, growth charts, everything revolves around all the four parameters. And next important thing is dating in pregnancy. If the patient, the dating is done in first trimester with CRL, it is correct. But for different reason, patient comes to you direct in the second trimester, you have to date the pregnancy by head circumference and or femur length. These two indicators are very accurate when we do dating in second trimester. Then biparietal diameter. Transthalamic view is always taken for these measurements. You can also measure BPD and HC by transventricular view. It is the transfer view of fetal head at the level of thalami. These two are thalami. Ideal angle of isolation should be 90 degrees. That means this should be perpendicular to the ultrasound beam. And symmetrical appearance of both hemispheres should be there. The midline echo, that is Fox, midline Fox should be seen. And this is the rectangular area. This is called as cavum septum pellucidum. This should be seen in each and every axial section of fetal brain. And cerebellum should not be visible in these planes. And BPD is taken from outer to outer diameter of the fetal skull. Many studies have shown that outer to inner diameter also be taken, but it depends on which charts you are using in your machine. So now recently ISWAG has published for outer to outer diameter measurements. And hair circumference is taken as ellipse around the fetal skull, or it can be taken in another way, like you can have occipital diameter and BPD, and various formulas are available in your machine that will give you direct measurement of head circumference. So this is transcerebellar plane. This is transventricular plane. There are three biometrical parameters in transcerebellar plane. First is transcerebellar diameter. This is on-to-on diameter of the cerebellum. This is dumbbell shape. Next is cisterna magna. This is inner to inner diameter. And this is nuchal fold thickness. Outer to outer diameter. Outer diameter of the skull to outer diameter of skin. So remember that cutoff of this nuchal fold is 6 millimeter. Anything more than 6 millimeter is abnormal, and you should alert the clinician for looking at some genetic diseases. And this is transventricular plane. I see in both these planes, CSP is the main thing included. Transventricular plane is used to measure the diameter of ventricles at the level of parieto-occipital sulcus. This is parieto-occipital sulci, and it is measured at the level of parieto-occipital sulcus by and this way. Actually, ideally, this should be magnified, but for sake of demonstration, I have done this. Then next is abdominal circumference. This is the transverse section of fetal abdomen at the level of umbilical vein. This is the umbilical vein, this is the stomach, and this is the spine. So it should be as circular as possible. Fetal spine should be preferably at 3 o'clock or 9 o'clock position for correct measurements. You can have elliptical, you can have apply ellipse all over the abdomen. Or another way is you have transverse diameter and anteroposterior diameter. With formulas in your machine, you get abdominal circumference. Now look at the anatomy. It is the transverse section including umbilical vein at the level of portal sinus. This short section of umbilical vein is the correct way of measuring it. Then stomach should be visible here. And kidney should not be part of this image. That is the perfect image. Kidney should not be involved in this. The next is femur length. Both ends of the ossified diaphysis should be visible. These both ends. The longest axis is measured, and the ultrasound beam should be perpendicular to the shaft of this femur. So some 10 to 15 degree deviation is permitted. And caliper placement should be at the ends of ossified diaphysis without including the distal femoral epiphysis in third trimester actually. And it should not include small spur artifacts also. Then estimated fetal weight. There are various formulae available for estimated fetal weight. Hadlock 1, 2, 3, various other formulas are available. But recently, Hadlock 4 is supposed to be the accurate formula for estimated fetal weight. It covers all the 4 parameters: BPD, HC, AC, and FL. Hadlock 3 have only HC, AC, and FL. And always use the word language of centiles. Estimated fetal weight is 1.2 kg. This is not the way. Estimated fetal weight is falling on this and this percentile for that gestation rate. This is the best way, proper way to speak in fetal medicine. And always use growth charts when you are examining the patient periodically at your center. That will give you information about the trajectory of growth, and you will diagnose the growth disorders like fetal growth restriction immediately looking at these growth charts. Then basic thing, anatomical survey. So this is the list of things which should be seen from head, face, neck, chest, heart, abdomen, skeletal, placenta, umbilical cord, genitalia, and cervix. We will cover one by one. So fetal head, coming to fetal head, there are 3 important planes in fetal head: transventricular plane, transthalamic plane, and this is transcerebellar plane. So in all planes, you should show that the cranium should be intact, head shape should be normal. Cavum septum pellucidum, CSP, this quadrangular area or a triangular in this case, this should be the most important and unique part which should be there in all these 3 planes. That means that your imaging is perfect. Midline fork should be normal in this case. Midline fork is a transverse line. This is midline fork. In transthalamic plane, you should have both thalami seen here. These are 2 thalami. In transventricular plane, these are the 2 lateral ventricles with coronary plexus in this. And in transcerebellar plane, you have got this dumbbell-shaped cerebellum with the biometry I have mentioned in the previous slide. Now, these are some abnormalities. This is ventriculomegaly. This atrial width diameter is more than 10 centimeter. It is ventriculomegaly. This is Dandy-Walker syndrome. You can see the dumbbell-shaped is lost. The area of Vermes you can't see here. Then this is anencephaly. You don't see any cranial vault here. This is holoprosencephaly. You don't see any midline forks here. There is monoventricle, and the thalami are fused. They are unclear thalami. You can diagnose this thing in first trimester from in 11-week scan also, because nowadays the patients are coming in first trimester very early in pregnancy, and because of very good machines and good expertise, many anomalies are seen in first trimester only. Second trimester, you have got very now less chunk of the patients in rural area or where the ultrasonography facility is not available. Again, this is the encephalocele. You can see the brain tissue coming out of this skull vault. And these are the signs of agenesis of corpus callosum. You can see the corpus CVSP is not visualized here. Cavum septum pellucidum. You can see three line sign is there. Again, colloquial is there. And on sagittal section, you don't see any corpus callosum. Now, next is face. Face can be seen on sagittal section as well as coronal section. In this section, you should see both orbits and bulbi along with lenses. Mid-sagittal facial section of the face gives you very important things, lot of things This is the facial fetal profile. You can see the abnormalities in the frontal bossing. You got to see the whether fetal nasal bone is there or not, whether it is anossified or hypoplastic. Here are the two lines are there. This is humor and this is palate. It is also called a superimposed sign line, which is indirect marker of if you see only single line, it is indirect marker of cleft palate, and you can diagnose micrognathia in here. This is the normal chin. And on coronal view, you get this nose, upper lip, lower lip, and chin. Upper lip should be intact in all these cases. Again, one more thing is there. Actually, looking at the ears and pinna is not part of ISO guidelines, but if always you should have good practices. If the patient is looking downwards, spine is up. If you tilt your probe sideways on the head, you may get these beautiful pinnas on your screen. So it is better to get into this practice. So these are some abnormalities. This is cleft lip, obvious cleft lip. This is cleft palate. You can see the defect in lip as well as the alveolar arch here. This is microcephaly. Again, you can see that this is unossified nasal bone. You don't see any nasal bone in this area. This is normal fetal face with both orbits, but in this image, you don't see one-sided orbit. This is anophthalmia, and this is obvious finding of micrognathia here. This baby landed up in polyaromnias, and the cause of this was obvious micrognathia. The next is neck. The presence of obvious neck masses should be documented here. This is the region of neck. There is no much thing to demonstrate or to look at this because the obvious, anything in this position is obvious. The neck normally appears as cylindrical with no protuberances, masses, or fluid collections. Obvious neck masses such as cystic hygromas, goiter, and teratomas should be documented. One more thing regarding
Madam Kalpana, madam, please mute yourself.
Support team, mute everybody. Support team, mute everybody. Support team, mute everybody.
बार-बार बोल रही हूँ बच्चेदानी तो ठीक है मार्च पर एक साइड में एक छोटा सा ऐसा मास जैसा लग रहा है मैंने पिछले बार भी बताया था क्या चीज है वो देखना जरूरी है ठीक है अभी तुमको जो तकलीफ हो रही है उसके लिए गोलियां दे रही हूँ पेशाब में जलन हो रही है
good consultation for everyone here.
बार-बार जाना पड़ रहा है ऐसा कुछ नहीं
I'm calling
कमर की तरफ है ना
अभी एकदम नहीं हो रहा है अभी थोड़ा कम है मैं तो बीच में भी 4-5 दिन से बहुत हो रहा था पेट में
Let's continue. So these are the images of congenital goiter here. You can see the obvious swelling here with good vascularity. These are the 3D images, and this is teratoma with septations here. One more thing to see at the level of neck or just cranial to it is the equal to sign. This is the pharynx, and with this, when there is fluid in pharynx, you can see these two echogenic lines, and these are the lines of uvula. And when you see this uvula, it is indirect sign. It tells you that the palate is intact. Of course, this is not part of ISO guidelines, but as you start to look at these points also, so that your imaging is somewhat advanced. Now coming to thorax. The basic examination of the thorax should include assessment of its shape, transition to the abdomen and shape of ribs, the texture of lungs, and when feasible, visualization of the diaphragm. The shape of thorax should be regular with a smooth transition to the abdomen. The ribs should have normal curvature without deformity. Both lungs should appear homogeneous without evidence of mediastinal shift or masses. See, we don't specifically look at lungs. Whenever you look at the fetal heart 4-chamber view, you obviously have a look at fetal lungs, and any abnormality there is caught definitely and spontaneously there. The diaphragmatic interface can often be visualized as a hypoechoic dividing line between the thoracic and abdominal content. This is the line of diaphragm, and this image should be given to all patients because some cases of diaphragmatic hernia, you can see the stomach is intra-abdominal content, and when in diaphragmatic hernia, stomach herniates into the thorax in some cases, but this is seen in late 3rd trimester in some cases. So when your image is showing that abdomen is the stomach is in the abdomen, and in 3rd trimester it can go into the thorax, this you can explain to the patient that this is an evolving anomaly. So see, in this case, these are abnormal things in thorax. This is congenital diaphragmatic hernia. You can see the herniation of stomach into the thorax, pushing the heart to opposite side. This is CPAM, congenital pulmonary airway malformation, cystic variety. This is the cystic lesion seen in thorax. You're pushing the heart to opposite side. This is bronchopulmonary sequestration. This is echogenic triangular area of the lung tissue. in thorax above diaphragm, and this is chaos, congenital high airway malformation syndrome. There is hyperinflated airways pushing the heart into the center, causing mesocardia. This is called as mesocardia. In fetal heart, there can be a 3 to 4 days full conformation of fetal heart. So there are so many things which can be spoken on fetal heart, but there are some basic things in fetal heart. There are 5 important basic planes when we are looking at the fetal heart. So number 1 is 4-chamber view. This is the 4-chamber view at the thoracic level. So the chamber in front of the spine is left atrium. This is left ventricle, right atrium, right ventricle. And this much anatomy or this much imaging should be done by all obstetricians. Next is left ventricular outflow. This is left ventricle and this is going toward the shoulder. So most important thing in this image is septo-aortic continuity. That means this septum, interventricular septum, is continuous with the wall, anterior wall of aorta. Next is 3-vessel view and 3-vessel trachea view. PAS, pulmonary artery, aorta, and superior vena cava. And next is right ventricular outflow tract. This right ventricle coming, the branch coming from this is pulmonary artery, which is branching. And you can see, if your machine is good quality, you can see this hypoechoic area at this region at the level of 3-vessel trachea view. This is the thymus. Because thymic hyperplasia is associated with many abnormalities with 22q microdeletion syndrome, which is associated with many cardiac diseases. You can have use of color. This is 4-chamber view. This is 3-vessel trachea view. This is the low settings to visualize pulmonary veins. This view is very, very important to demonstrate the entry of pulmonary veins into atrium, left atrium. And this is the normal right subclavian artery. This is the famous handlebar sign, bicycle handlebar sign. This rules out ARSA, aberrant right subclavian artery, which is the aneuploidy marker in 2nd trimester. So these are some abnormal things. This is cardiomegaly with some pleural effusion. This is Epstein's anomaly. You can see the enlarged right atrium with tricuspid regurgitation. Then this is ventricular septal defect. You can see the flow of blood from here to here through this septum. This is hypoplastic left ventricle. The area of left ventricle is very, very small. This is hypoplastic right ventricle, seen in many cases. And this is the aorta here, the overriding of aorta seen here. This is the ventricular septum, and this aorta is sitting on this ventricular septum. And this covers a bunch of anomalies in cardiac cases like tetrahedral fallow, DORV, or common arterial trunk, and so on. Now coming to abdomen. In abdomen, stomach should be normal in position on left side. The boil should be normal. In routinely, we don't look at the boil, but high-end machines with high frequency probe, you can see the large, small boils where the mucosa is seeing very echogenic things. The gallbladder should be on right side. Again, looking at the gallbladder and documentation of gallbladder is not included in ISWA guidelines, but it is always good practice to have this. Or if there is history of biliary atresia in the previous child or in family, you have to look for that in this pregnancy also. Both kidneys should be present, no pyrectasis. Urinary bladder is normal in appearance, and cord insertion site into the fetal abdomen normal. This is the image of cord insertion. It should be seen that the intra-abdominal as well as extra-abdominal part should be there in your image, and it's ruled out small omphalocele also. And this is the image of bladder with color, and these two things denotes umbilical arteries. This rules out single umbilical artery. These are abnormalities. This is the free-floating intestine loops in the abdomen. This is the case of gastroschisis. Again, this is gastroschisis. This is omphalocele. This is again omphalocele seen in 1st trimester. And this is another rare case of bladder extrophy actually. This tissue is the exposed bladder mucosa, which is come up into the abdominal wall. Now, kidneys and bladder. Kidneys should be seen in 3 ways in pregnant woman. First, this is the axial section, and the measurement of fetal pelvis is taken in this axial section from on to on in like this case. And you can see in parasagittal when you look at the spine, just tilt your probe to one side, you get right kidney. On the other side, you get left kidney. And on coronal section, you get both these kidneys on either side of the spine. So there are various cutoffs for first trimester, 2nd trimester, 3rd trimester for these renal pelvis measurements. but anything more than 4 millimeter is abnormal in second trimester. So these are abnormal images. This is very much dilated renal pelvises. This is multicystic dysplastic kidney. This is the same thing. These are the echogenic kidneys, echogenic and enlarged kidneys covering a large spectrum of genetic diseases like ARPKD, that is autosomal recessive polycystic kidney disease, or can be cause of any infections and so on. So just you have to look at the echogenicity. Then coming to skeletal, coming to spine first. Spine is seen again in three ways. First is the sagittal section. You can see this. There should not be any breach in the continuity of skin. The most important thing when you are looking at the skeletal system is there should be a pocket of liquor above this spine, above the skin, so that any subtle defect can be caught up. This is the coronal section of the spine. Many abnormalities like hemivertebra are seen in this section only. And third section is the sweep, transverse sweep from cervical vertebrae to sacrum. A slow sweep is taken so that small defect is noted, identified at that space. Arms and head should be present, normal joint position. Legs and feet present, normal joint position. Here you should see humerus, radius ulna, as well as femur, tibia, fibula. Both sides should be second. Only looking at one side is not sufficient. You have to look for all three segments: femur, tibia, fibula, and foot, humerus, radius ulna, and hand. Counting of finger is not required as per ISO guidelines, but again, it is good practice to look at the number of fingers which you have a good machine and the fetus allows for that. And the measurement of one femur is usually sufficient unless there is suspicion of abnormality. If you are suspecting skeletal dysplasia, then you have to measure all the long bones. So again, these are abnormal cases. This is the defect in the spine, spina bifida. This is club foot, the alignment of the tibia and fibula, and this foot is abnormal. You can see here. Again, here the femur is short here, deficiency, focal femoral deficiency, and this is the board femur seen in various cases of skeletal dysplasia. Then coming to amniotic fluid assessment. Amniotic fluid can be assessed by two ways. You can have amniotic fluid index as well as you can have single deepest pocket. So when we talk about polyhydramnios, usually you give a report of in terms of amniotic fluid index, and when we are looking at oligohydramnios, we give the report in terms of single deepest pocket. So for amniotic fluid index, we divide the abdomen into 4 quadrants, keeping the umbilicus at the central region: right upper, left upper, right lower, and left upper. And in that region, we look for the single pocket which is free of umbilical cord and any fetal part. And you measure vertically in all 4 quadrants and measure, add these 4 quantities to give a amniotic fluid index. Or else for SDP, you screen whole abdomen and look at the largest pocket, vertical pocket for that. The normal range of SDP is 2 to 8 centimeters. Anything less than 2 centimeters is oligohydramnios. Anything more than 8 is supposed to be polyhydramnios. There are charts available, percentage values are available on net for respective gestational ages and Liker quantity. So when you are seeing at the polyhydramnios, there could be some anomaly in the baby. So you have to look from head to toe. There should be some CNS pathology which prevents the baby from swallowing. Then you have to look at the cleft symphysis, any giving pressure like a mass water on the neck. In thorax, we have seen the images of congenital diaphragmatic hernia, CPM, or bronchopleural sequestration. In abdomen, stomach bubble should be seen. Absent stomach bubble or minimally distended stomach bubble can be indicator of tracheoesophageal fistula, and that can be cause of your polyhydramnios. Kidneys. This is again uretropelvic junction obstruction. This is a strange indication of paradoxical polyhydramnios. Look at extremities. That is arthrogryposis. That means the very minimum mobility of the fetus. Then lower spine and pelvis, look for sacrocoaxial teratoma. A big teratoma is obvious things, and in placenta, large chorioangiomas can result in polyhydramnios. So when the baby is structurally normal and there is polyhydramnios, you can think of 3 things. One is maternal diabetes mellitus. Second is alloimmunization, that's Rh negative baby, Rh negative patient, and congenital infections. And so your investigation should be focused on these lines. Then oligohydramnios, again, the pathogenesis goes in 3 directions. Number 1, Spontaneous PROM, this is the commonest seen in acute cases. Second is renal anomalies, because most of the liquor is in the form of urine secreted by the baby. And third is again hypoxia, chronic or intermittent hypoxia. There is redistribution of blood flow through vital organs, less blood supply to the kidneys, less urination, and that results in oligohydramnios. So one thing about amniotic membranes, we have heard the word like chorioamniotic separation. Actually, chorioamniotic separation is a normal thing till 15 to 16 weeks. After 16 weeks, the chorion and amnion, they fuse. If they are not fused after 16 weeks, they are continued to be separate after 16 weeks, that may result in abnormal outcome like fetal growth restrictions or preterm delivery or hemorrhages. And this is again amniotic band. So you should be differentiate between amniotic sheath and amniotic band. Amniotic sheath, these are nothing but the amniotized synechia. Just amnion is passing over this. These are benign findings. But amniotic bands, these are dangerous things. Amniotic bands should be diagnosed when they are attached to any baby part of baby like finger or face, and there is deformity at that point. So amniotic sheaths are benign findings. Amniotic bands are dangerous. They may result in anomalous baby. And you should have noticed, look at the fetal movements. Normal fetuses typically have a neutral position and slow regular movements. Temporary absence of or a reduction in fetal movements during the scan should not be considered as a risk factor. Abnormal positioning, usually restricted or persistently absent fetal movements, may suggest abnormal fetal conditions like arthrogryposis. And BPP, biophysical profile, is not considered as a part of routine mid-trimester scan. It is usually we see in third trimester, not in second trimester. Then umbilical cord, again, look at the insertion. We covered this in placenta section also. In 80% of cases, the insertion of umbilical cord is the center of the placenta. But in 20% of cases, it is within 2 centimeters of the insertion, and this is called as marginal cord insertion. The clinical indication importance is that in marginal cord insertion, the amount of nutrients coming to baby are less. So these babies may land up in fetal growth restriction and other conditions. Again, single umbilical artery. When you put in color at the bladder region, you should see 2 colored arteries, umbilical arteries here. Here only 1 umbilical artery is there. So this is indicative of single umbilical artery. Again, it has got 2 implications. Number 1, it is a marker of trisomy 18. So if along with this finding, you have other markers of trisomy 18 like CP cyst or clenched hand, your investigations should be directed on genetic evaluation of the baby. The screening and definitive testing, this is not part of this talk. And second thing, single umbilical artery can be associated with fetal growth restrictions in some cases, especially in twins. But isolated finding of single umbilical artery is not considered to be very dangerous or untoward thing. Doppler. Routine use of Doppler, there are no current is sufficient evidence is there, but I'd like to tell that about uterine artery. Uterine artery Doppler should be seen in all cases after 11 weeks because it is a screening for preeclampsia. So when the baby crosses 11 weeks, each and every scan should have a report of uterine artery Doppler. Next, umbilical artery Doppler. Usually umbilical artery Doppler is seen after 24 weeks, especially when we suspect TTTS in twin pregnancies, monochromatic twin pregnancies. Routinely in single pregnancies, when there is no complication, we don't see umbilical artery at this stage. Only when TTS is suspected, we start looking at from 24 weeks. Again, MCA, middle cerebral artery, we look at middle cerebral artery in third trimester usually, but in second trimester, only one condition is there when we look at MCA, that is PSV, peak systolic velocity, when we are looking at the anemia of the fetus in RH simulation. So peak systolic velocity of MCA gives you a lot of information about the hemoglobin status of the baby. And coming to placenta. Routinely, we look at the placenta for 3 reasons. Number 1 is echo texture. Look for any hemorrhageous masses cyst. Second is cord insertion, which is described in previous slide, that is whether the cord insertion is marginal or central. And third is distance of the placenta from the internal os. If it is coming within the 2 centimeter of distance, we label it as low-lying placenta. Apart from these things, nowadays, we need to see many more things about placenta in the view of placenta acute spectrum disorders. So This is the, you can see, this is posterior placenta covering the internal os. This is obvious case of placenta previa. Then few words about PASS, placenta active spectrum disorder, because everyone is very much worried about placenta active spectrum disorder. You should know the signs of placenta active spectrum disorders when you are looking at the patient. Number one basic thing, if the woman is having previous cesarean section and finding of this much placenta, this type of placenta previa in current pregnancy, there are some grayscale imaging signs, there are some color Doppler imaging signs. So grayscale signs are loss of clear zone, myometrial thinning, placental lacunae, bladder wall interruption, placental bulge, and focal exophytic mass. And the color Doppler imaging signs are utrovesical hypervascularity, bridging vessels, subplacental hypervascularity, and lacunae fluidary vessels. We will see just images of those. So you can see the loss of clear zone. This is very, very important. You can see this clear zone, hypoechoic zone behind this placenta very nicely. And each of you should be trained to look at this clear zone from today onwards in each and every patient, so that you will not miss out this loss of clear zone. You can see here the clear zone is not there. Compare these two images. Next is myometrial thinning. This is very nice myometrial texture in these two images, and see here in abnormal cases myometrial is lost. It is undetectable in these two cases. Then placental lacunae. We call it placental legs in normal placenta. These some legs are there in the normal placenta. While these things are lacunae in abnormal cases like PASS. And sometimes it is very difficult to differentiate between normal lacunae and normal legs and lacunae. But lacunae they are multiple, and they are having very high blood flow within that lesion, crossing more than 10 centimeters per second velocity. Next is bladder wall interruption. You can see smooth bladder wall here, while there is obvious interruption in bladder wall in these two abnormal images. Third is placental bulge. This is the obvious mechanical thing in placenta active spectrum disorders. This bulges into the bladder directly, like this exophytic mass. This is going into bladder directly. This is case of placenta in percolata. In uteroplacental hypervascularity. So this uterovesical hypervascularity and bridging vessels, then again subplacental vascularity. All these are indicative of excessive blood supply in that region. And excessive blood supply is because of the thing that the basic thing in placenta active spectrum is previous injury, previous scar. Previous scar means the oxygenation at that point is very, very less. So when the placenta sits on that spot, it is looking for good oxygenation, well oxygenated tissue, so that it goes sprawl in adjacent areas like malignancy or cancer cells, and that creates hypervascularity everywhere. So instead of remembering all these names, if you see hypervascular state in these regions, you should alert your mind that you may be facing the case of placental active spectrum disorders. Then velamitous cord insertion. Here membranous umbilical vessels are present at placental insertion. It lacks Wharton jelly, so they are prone to compression and rupture. Then next is vasa previa. Here the fetal vessels present the membranes covering os, like this here. So there are two types. Type 1 is velamitous cord insertion. Type 2 is bilobe placenta subcentric lobe. And how to differentiate? When you put in Doppler here, it is equivalent to fetal heart rate. Then these are the bubbles and line signs seen in published and recent ESOG. These are the bubbles. You can see the bubbles, and these are the lines. When you put in color, these are the vessels. Then chorioangioma. This is the good image of chorioangioma. This is the placental chorioangioma, placental abnormalities here. Then placental variants, circumvallate placenta. This is there is small chorionic plate, growth of extrachorial placental tissue here, and there is a raised white ring around this. Actually, this is benign finding, but in some cases, fetal growth restriction can set in. And most important thing is fetal vessels do not cross this, as opposed to subcentric lobe. Well, coming to this, subcentric lobe is additional or accessory lobes found in comparison with other primary lobes. The placental artery and vein extends from main placental mass. This is the problematic thing in these cases, and they runs through intervening membranes. So when it comes over the internal os, it becomes vasa previa. And another thing, clinical important thing is after delivery, this may be retained, subcentric lobe may be retained. So the clinician should know the sonography report of that patient, that this patient is having subcentric lobe. So you have to wait for that another lobe, other part, or you have to remove this part. So this is the primary lobe. This is the secondary part of placenta, and you can see the vessels are interconnecting this area. So if this area is at the level of internal os, it gives rise to vasa previa. In cervix, vasa previa, just I have discussed. Then cervical length. Measurement of cervical length transabdominally will not give the correct way or correct answer. So perfect measurement of cervical length is by transvaginal approach. You can see like this is the normal transvaginal length, and you can see the short cervix, this is 14 millimeter. And depending on the previous obstetric history, preterm deliveries, you have to discuss the options of PG, progesterone and cervical ensilage. So to conclude, second trimester scan is most important scan because it gives information about all the anomalous structures and anomalies. It gives information about various growth disorders if they are caught up early in pregnancy. And again, expertise is very, very essential to do second trimester scan. This is not very difficult. Once you are trained to look at normal things, then you can pick up abnormal things very, very early. Thank you. Thank you for your attention. Thank you for being online.
Thank you, Dr. Sujit, for very nice lecture. And especially your images are very good. When I see all images, it's very clear and very good. And I think every gynecologist or obstetrician who attended the CME webinar just benefited because of your placental localization. All the pictures and your point for polyhydramnios and oligohydramnios are very good. I just want to ask you that any gynecologist or obstetrician can do this label 2 sonography. We are
Yes.
eligible
Yes,
without
yes.
doing any fellowship in fetal medicine, etc.
Without doing any training, you can't dare to do a second trimester scan. Legally, you can do, but you can't do blindly. No? Legally, you can do. You know,
Means obstetric gynae, MS obstetric gynae can do label 2 sonography.
only this much qualification is sufficient for doing this.
Okay. Second trimester screening.
Yeah. Bella ma'am, you want to comment on this?
Yeah, exactly. Once you do, whenever you say that I am doing anomaly scan, you should know yourself that you are competent enough. For that, you should have taken training to
Yes.
standard way. So legal thing is different, and doing it in
Practical thing is different.
because unless until we are confident about doing the things and we know for sure that we'll be able to give a standard report to the patient, we should not say that or we should not start doing it, because doing it in a substandard way will be even more
Put in
dangerous,
trouble.
I would say. So it's always on our part, it's our responsibility to train ourselves to do the scans in a standard manner. And that's the reason why we have all such webinars and all. Monica and all are doing good work.
Because I am always worried and sent to radiologist for this all legal purpose.
No. Legally, you can, of course, you do, but you have to train yourself.
Yes.
Actually, yeah, Dr. Anju, very valid question, because I think when I start my talk, it is going to be something like this also.
Yeah.
Fertility specialist or routine OBGYN, what level of ultrasound we can do, how we can train ourselves. Bela ma'am is having a very nice educational WhatsApp group at present, in which so many queries come, and despite her busy schedule, madam is always answering questions. And there it was, madam, her aim is that even the routine OBGYN, if he or she is focused on enhancing her or his skills, everything is possible, but it cannot happen in a day. It requires patience, training, time.
But
everything.
actually, if anybody says that you are trained or not trained, we can say how it is, can we say that it is trained or
Very
not trained?
haphazard. It's very haphazard. It's up to you when you know, when you are sending reports to someone, you know that, the reports are up to mark. The images, you have to look at the images, you have to look at the reporting, and you have to, time to time, you come to know somebody is doing it in a standard way. Of course, if somebody's done fellowship and all, you know for sure that, they have taken training, they have their degrees, that's a different issue. Otherwise, even if you are sending to radiologists, there are good radiologists, there are not so good.
They also have mistake many times.
Yes, because then relying on something which is not done in a standard manner can put you
Yeah.
also into, a soup sometimes. So you have to be very careful in that.
Thank
Yes,
you.
right message.
In fact, I called up Bela ma'am 4 days back, in which I asked her, because one of my juniors came to me, who is known to me. I did IVF for her. So now she has a little child and she is going for training for 6 months to a reputed center. And after 6 months, she wants to start practicing fetal medicine full-fledged. So I asked Bela ma'am, is it right to do a 6 months training and keep a label of fetal medicine specialist? So that is a gray zone, I think. Madam also explained that way. So thank you so much for the wonderful lecture, Dr. Sujit. I understand you have other commitment, and as destiny would have it, आपका lecture ही पहले हो गया. So, so Bela ma'am, just give me 25 to 30 minutes to finish the first trimester this thing. I have already been introduced, so nobody can stand more of my introduction. And I will straight away proceed with sharing my slides. My slides visible?
Yes, yes.
Yes, thank you. Thank you so much. So I start with the very basic lecture, and Dr. Anju, this will solve many of your queries as to how much a routine OBGYN and a reproductive medicine specialist, as you yourself are, can delve into ultrasound, how much time can we spare, how much motivation we have, and what skills we can develop. So I will be speaking on this very, very exciting world of early pregnancy scanning. And we know that as technology has advanced, we are getting all these beautiful, beautiful machines in our, clinics and centers. And any sufficiently advanced technology is actually indistinguishable from magic. These are the magical images of early pregnancy we can render on 3D. This is the type of images you show to your patient. She is so happy, amazed, astonished. And this is not to just, give a hype. This is actually going to help create a positivity and a bond between the obstetrician and the patient. The route of ultrasound for diagnosis and assessment of early pregnancy is very important, and it has been categorically proven that transvaginal ultrasound is the imaging modality of choice in the evaluation of a first trimester pregnancy because these are high frequency probes. They go close to the area of interest, they give highest resolution images, but at the same time, the penetration is lower. Or in contrast, when you use a transabdominal probe, these are lower frequency probes. The resolution is lower, but you get higher penetration. So the sonologist must be familiar with the sonoanatomy of the pelvis, the normal early pregnancy, the abnormal early pregnancy, normal pregnancy in abnormal location, and abnormal pregnancy in normal location. And any misunderstanding of these vital, areas may lead to incorrect diagnosis and incorrect treatment. The sonoanatomy I wanted to emphasize was you should get familiar with the transvaginal probe right from your residency days. And you should know how to differentiate between an anteverted uterus, a retroverted uterus, what is the endometrial stripe, where is the internal os, where is the external os, both the lips of the cervix, the anterior myometrium, the posterior myometrium, because this is where your early gestation is going to start and you are concerned with its location, its viability, and the gestational age. So what actually do we want to assess in the first trimester scan? We definitely want to know whether there's a gestational sac, what is the viability, whether you're able to see the yolk sac, the fetal pole, the cardiac activity. Then ultimately you will go on to the measurements like measuring the gestational sac, measuring the CRL, finding the number of fetuses, ruling out multiple gestation, ruling out an ectopic and rarely an heterotopic. I recently had to, had this very horrific experience of a heterotopic following IVF, which is common in that case. But ultimately it was a bad experience because I did laparoscopic surgery for the ectopic gestation. And after 2 weeks, the intrauterine also went for a missed abortion. So these things keep happening in ART practice. Definitely, we have to keep in mind the surrounding structures, any abnormalities of the uterus, cervix, ovaries, and ultimately advance our skills in so much so that we can go to the 11 to 14-week scan confidently and start doing the NT scan according to guidelines. So what are the definitive signs of an intrauterine pregnancy? These are 3 in number. Number 1, the yolk sac. Number 2, the fetal pole or the embryo. And number 3, the fetal cardiac activity. So if there is failure to identify a definitive intrauterine pregnancy, should you panic? No, because in 1/3 of the cases, it may be a very early normal intrauterine pregnancy. The LMP might be, just mistaken by the patient, and you give some a week or so to the patient, the sac will appear. In half the cases, it may be an abnormally developing intrauterine pregnancy, or it may be a pregnancy which is progressing towards miscarriage. And in 1/6 of the cases, or even less, it might be an ectopic gestation. So do not diagnose at the first scan. And the earliest sign of pregnancy on ultrasound is actually what is known as the intradecidual sign. In about 35% of the cases, you do not get this sign, and it is actually visible at around 4.5 weeks as a small ring. So what happens is, at around a few days after the missed period, you start seeing a small cyst-like structure, anechoic, with a central anechoic area and an echogenic rim around it, which is situated eccentric to the in the endometrium of pregnancy, known as the decidua. The central stripe of endometrium is not disturbed, and this is known as the intradecidual sign. The pitfall in seeing and diagnosing pregnancy with the intradecidual sign is sometimes there may be an endometrial fluid collection which may be misdiagnosed as an intradecidual sign and a pregnancy. Sometimes there may be a decidual cyst. So you have to definitely correlate with the patient's history, her pregnancy test, any ovulation induction which has been done, and of course the beta HCG levels in cases of doubt. Next, we come to something known as, again of academic interest, is double decidual sac sign. Double decidual sac sign occurs when the pregnancy has gone a little further. About 1 week after the missed period, you see a rounded or oval fluid collection, anechoic, and remember, the true gestational sac is almost always eccentrically placed. It's never in the center. Here it is surrounded by 2 echogenic rings. The outer one is the endometrium of pregnancy, known as the decidua, and the inner one is the slightly hypoechoic chorion. There are several pitfalls associated with the double decidual sac sign, because sometimes you can get a pseudo-gestational sac. This is usually seen in cases of ectopic gestation, where fluid or blood from the tube accumulates inside the endometrial cavity. And this fluid collection is not totally round or ovoid in shape. It has got acute angles, a teardrop shape, and only one faint echogenic rim around it, which is the endometrium. So a pseudo-gestational sac can be mistaken with the true gestational sac. You should know how to differentiate. So why is the yolk sac so important? Yolk sac is a definitive sign of pregnancy and a valuable indicator of early pregnancy viability, and the shape, the size, the rim around it is also suggesting how healthy a pregnancy is progressing. Abnormalities like a very large yolk sac, a misshapen yolk sac, absent yolk sac, calcified yolk sac are all associated with increased risks of miscarriage, and they require a stringent follow-up. The presence of a yolk sac also helps you to label a true intrauterine pregnancy, and you can, a little confident you become that your pregnancy is going well. So the yolk sac is seen after you cross 5 weeks of pregnancy, around 5.5 weeks. This is a confirmatory feature of intrauterine pregnancy, plays a critical role in providing embryonic, contributing to embryonic development by providing nutrients. And basically the number of yolk sacs is equal to the number of amnions. So in multiple gestation, you can count yolk sacs to determine the amnionicity. And when does the yolk sac disappear? It disappears when the amnion grows large enough to fuse with the chorion. And this happens at around 14 to 15, 16 weeks of gestation. And this is the time when placenta takes over in transferring nutrition to the fetus. Now, there's a very interesting sign in early pregnancy, which you can enjoy on TVS whenever you get an early pregnancy. And this gives a signet ring appearance. So all women are fond of diamonds. And this is the diamond appearance you see in an intrauterine pregnancy. At around 6 to 6.5 weeks of gestation, there's a little dot-like embryo which appears on top of the yolk sac. So this embryo appears like a diamond, And cardiac activity flicker can also see inside it, because usually the appearance of the embryo coincides with the appearance of the cardiac activity. It is sometimes suspicious and sinister if you see the embryo and do not see the cardiac activity. So this gives the typical signet ring appearance. And after this, closer to 6.5 to 7 weeks, you start seeing around the embryo with the heartbeat, a thin membrane, a very thin, regular looking membrane surrounding the embryo. So this is the amnion. Now the embryo starts becoming, is intraamniotic, and the yolk sac becomes extraamniotic, freely floating in the chorionic activity. So you can appreciate the fetal heartbeat very well by applying the M mode. It is advisable, like Dr. Sujit said, not to use Doppler unnecessarily, especially in the first trimester. The Doppler may have no adverse effects on the mom, but you should be very vigilant that you should not be using Doppler, especially dwell the probe for a longer time with Doppler at any one place. And you can very well document the fetal heartbeat without using the Doppler. So what happens after this? The amnion starts expanding after 7 weeks. The yolk sac is now freely floating out in the chorionic cavity. So the main feature is now the amniotic cavity with the embryo, and you will see the characteristic change in the shape of the embryo. You will see a tiny dot, then you will see a rice grain appearance, and finally the embryo grows to form that typical kidney bean or rajma shaped structure, which you're so familiar with. So now the embryo can be called a fetus. After 9 to 10 weeks, you start calling it the fetus, and by the end of 12 weeks, almost organogenesis is complete and the amnion is ready to be fused to the chorion. So this is the order of appearance in early pregnancy. I know this is very basic lecture, but I feel it's very important when we scan our patients. We see the intradecidual sac sign, the double decidual sac sign, the yolk sac, the pulsating embryo, and the amnion. So these are the beautiful images which you can practice on your machines, the sequence of events. And sometimes you do not see the intradecidual sign or the double decidual sign. Do not be worried, because these signs are absent in 1/3 of the intrauterine pregnancies. Coming to the CRL, CRL is a very important measurement. It includes the straight line drawn from the top of the fetal head to the buttocks. And this gives us a very accurate idea of the gestational age. And the earlier in pregnancy the CRL is measured, the more accurate is the mean gestational age assignment. The measurement of the CRL should be done according to guidelines. A mid-sag plane is preferred, fetus in neutral position, have adequate magnification. The initial age assignment, once done, should not be revised on subsequent scans, because then you are likely to make a mistake. And overall, the accuracy of sonographic dating in the first trimester is ±5 days with a 95% confidence range. Another measurement which is important in early pregnancy is the measurement of gestational age. Often we are confused, gynecologists, how to measure the gestational sac. Remember, you have to measure the anechoic rim to the anechoic rim, exclude the echogenic rim, measure the length, height, and width, and divide by 3. What is a failed early pregnancy or an early pregnancy loss? This refers to the death of the embryo, an abnormally progressing gestation, and a miscarriage. The most common cause is chromosomal abnormalities, and there are certain findings in the first trimester scan which you can confidently say are diagnostic of early pregnancy loss. Number 1, CRL more than or equal to 7 mm and no heartbeat seen on TVS. Number 2, mean sac diameter more than or equal to 25 mm and no embryo seen on TVS. Number 3, absence of embryo with heartbeat 2 weeks after a previous scan that had shown gestational sac without a yolk sac. Number 4, absence of embryo with heartbeat 11 days after a scan that showed gestational sac with a yolk sac. Number 5, embryo irrespective of CRL, which has got no cardiac activity on initial scan and no cardiac activity on a repeat scan done 7 days later. And lastly, cessation of previously documented cardiac activity in an embryo irrespective of CRL. So these tips, when kept in mind, will help you explain better to the patient when a mishap occurs. Can you do fetal anomaly detection by ultrasound in first trimester? My job has been made so easy by Dr. Sujit, but I'm just giving you an idea of which are the fetal anomalies in the first trimester which you should not miss, which may be potentially detectable, but you have to refer to a fetal medicine specialist, and which are not detectable, and you have to explain to the patient that there's a group of anomalies wherein you may have to wait for second trimester. In the chronology of things, they appear later. So these are the types of anomalies which appear as gestation advances. The always detectable fetal anomalies in the first trimester, 11 to 13 week scan, are as follows. Number 1, acrania, alobar holoprosencephaly, both lethal anomalies, omphalocele gastroschisis, megacystis, and body stalk anomaly, also known as limb body wall complex. So these are the always detectable anomalies, and no gynecologist who is interested in doing first trimester scans should miss these anomalies, because when detected early, they'll save the patient a lot of heartbreak and lot of pain, and you can, offer a referral and a termination if necessary in the first trimester itself. As you can see in these images, there is a defect in the ossification of the cranium. Here you can see alobar holoprosencephaly and a single ventricle. Here you can see a grossly thickened nuchal translucency. Here you can see an abnormal contour and probably a body stalk anomaly. Here you can see a mass protruding from the anterior abdominal wall omphalocele, and here you can see a megacystis. So whenever, I think I have seen a video by Bela ma'am in which she has said categorically that when you see a major structural anomaly on ultrasound, then screening is not required. You do not advise an NIPT. You simply go to invasive testing and take a definitive decision. So the normal cranial bone ossification in the fetal skull is properly, very nicely and clearly visible at 10 to 11 weeks. You see a properly ossified calvarium, a midline forks, and the butterfly-shaped choroid plexus in the first trimester. In acrania, this ossification is not visible. There is a mass, a brain, amorphous brain mass, which is available on the imaging, and a thin membrane may be seen around the mass, and this is known as acrania, and the floating brain gives rise to a condition known as exencephaly. Gradually, this brain matter absorbs or resorbs, and you get the typical appearance of no bone and no brain, that is anencephalic fetus. And here you can see that frog eye appearance in the coronal section. So these are the congenital anomalies which are lethal, should not be missed. And this goes through a particular sequence of dysgraphia, cranioschisis, exencephaly, and final anencephaly. We have been in the generation in the 90s when we did a post-graduation, we have delivered anencephalic fetuses because there was no ultrasound and the patients used to come full term with anencephaly, and it was very difficult vaginal delivery. Sometimes we had to do a destructive operation. So we were that time when, we have seen and delivered anencephalic fetuses. And this is the most common anomaly affecting the CNS, with the incidence in 1 in 1,000 pregnancies. Now, this is another lethal congenital anomaly where there is failure of cleavage of forebrain leading to a single midline ventricle and incompatible with life, known as alobar holoprosencephaly, may be associated with other midline facial defects and a proboscis. This is encephalocele, wherein the skull contour defects are there, usually in the midline, most common in the occipital region. You see this anechoic protrusion of the fetal neural tissue, which can be seen and spotted on ultrasound. And usually here, it's not an anomaly in which you advise termination. Very many of these conditions are amenable to surgery, and you have to have a special teamwork with your pediatric surgeons, geneticists, etc. Assessment of the fetal neck, head, and the skull region and upper thorax is very important. It's the classical, pick which is required for the NT&B scan. And according to guidelines, this should be the magnification. You should be able to see the whole of the fetal head and the upper part of the thorax. in the proper mid-sag section. And here you can see very nicely, once you try focusing the fetus in this plane, you can very well make out the nasal skin, the nasal bone, the nasal tip, the rectangular palate, and the spaces in the fetal brain, which are namely from medial to lateral side, you get the brainstem, the intracranial translucency, the future cisterna magna, and the nuchal translucency. And here also your skills will improve as and when you keep doing the scans. Another thing which is sometimes perplexing to us in the first trimester is what is physiological midgut herniation, why does it occur, and how can we differentiate it from gastroschisis. Now, we all know that the fetal gut elongates or grows at a rate that surpasses the growth of the fetal abdomen. So that leads the gut herniation into the base of the umbilical cord. This is known as omphalocele. The bowel of the fetus then rotates counterclockwise through 90 degrees around the superior mesenteric artery axis. This is why the normal anatomical position of the large intestine comes to the left of the abdominal cavity. But this herniation reduces itself and becomes normal by 12 weeks of gestation, should not measure more than 7 millimeter, and should not be seen once the CRL is longer than more than 44 mm. So this is the physiological umbilical herniation. You can see the omphalocele with the umbilical cord situated on the tip of the mass. And this usually, becomes, it rectifies itself by 12 weeks. And here also you can see at 10 weeks, this mass which is protruding out the physiological omphalocele with the umbilical cord at top. And by 12 weeks, the gut has receded inside and you can see the normal cord insertion. So what is the difference between omphalocele and gastroschisis? The two are different because in gastroschisis, the defect is not exactly at the umbilicus, it is paraumbilical, and the intestines are free floating outside the abdomen as in the form of a mass with no covering membrane. Whereas in omphalocele, if there is, viscera or gut, there will be a surrounding membrane and the umbilical cord is situated at the tip of the mass. The prognosis is different in both the cases. Here you can see clearly the the gut herniated in gastroschisis with the paraumbilical, placement of the gut and the umbilical cord on one side of it. So this is another picture of an omphalocele surrounded by a thin membrane, and this is gastroschisis with the free-floating bowel loop mass. And how do you recognize megacystis? Can you recognize as a routine OBGYN specialist? Yes, you try practicing the measurement of the craniocaudal bladder, and usually this measurement should be less than 7 millimeter. When this measurement of bladder in the craniocaudal direction is more than 7 millimeter, it is called megacystis. And in cases where the measurement is 7 to 15 millimeter, about 75% fetuses are euploid, and 90% of these cases resolve, and the megacystis also resolves. But 25% cases are aneuploid. And if this measurement grows to more than 15 mm, there is chance of progression to severe obstructive uropathy. And in some cases, the megacystis may be a transient finding. Definitely, you should advise a follow-up or refer. Another sinister and incompatible with life anomaly is the body stalk anomaly. This actually is a condition where there is gross anterior abdominal wall defect in the fetus with short or absent umbilical cord associated with severe spinal abnormalities and limb abnormalities. So here this is the fetus stuck to one side, the embryo stuck to one side of the gestational sac. You can see the misshapen limbs, sometimes absent limbs, and this is how it appears. This diagram I found very good, so I put it here. You can see there is no absent umbilical cord between the placenta and the fetus. The abdominal organs are herniated into the coelomic cavity through the large abdominal defect, short absent umbilical cord with severe kyphoscoliosis and limb anomalies. So this is another abnormality you should not miss. So what are the mostly and potentially detectable anomalies at 11 to 13 weeks scan? Here you might have to refer, or you might have to take the help of your fetal medicine specialist friend. Here the potentially detectable anomalies are absence of limbs, diaphragmatic hernia, which just now Dr. Sujit told us has got a timeline. lethal skeletal dysplasias, congenital heart defects, open neural tube defects. Sometimes you can see in the first trimester. And with very lot of vigilance and practice, you can even make out cleft lip and cleft palate. So these are the potentially detectable anomalies like facial clefts and neural tube defects. With practice, you can, make it perfect. Skeletal dysplasias are very easily detectable in the first trimester. You should learn the art of 3D rendering. This has made these are dysplastic limbs. This is a dysplastic limb which can be diagnosed once you focus the fetus and render in 3D. Again, a fetus with the right lower limb dysplastic. Facial clefts can be diagnosed in the first trimester once you increase your scan skill. So there are some anomalies which are not detectable in the first trimester because of the chronology of appearance of these abnormalities is later on in the gestational age, like agenesis of corpus callosum, cerebellar vermian hyperplasia, microcephaly, CPAM, bowel obstruction, renal abnormalities, fetal tumors, and others. Because they appear later on in fetal life, you cannot diagnose and you cannot give that diagnosis to the patient, and you have to explain the patient this fact. You should always learn, the gynecologist should always learn that whenever she sees the fetus or he sees the fetus, they should confirm the situs, the cardiac echo, and the stomach, both on the bubble on the left side. They should know how to visualize the short segment of umbilical vein, the stomach. Gallbladder may or may not be seen. That is not important according to guidelines. And of course, you should be able to, the kidney abnormalities are not very visible in the first trimester, but you can see lobulated structures in the renal fossa. You can put a short Doppler and see the renal arteries to confirm. And like Dr. Sujit said, the paravesical umbilical arteries, they progress to form the 3 triple vessel cord. So if you see the paravesical umbilical arteries, you're confident that the cord is 3 vessel cord. In the thorax, you should be able to see the symmetrical lung fields. The 4 chamber of the hearts are very beautifully visible with the current machines, including the integrity of the interventricular septum. You can see the spine. The fetus is small, handy, very much visible. The limbs are beautifully visible. The integrity of the spine, the overlying skin can be seen. All the 4 limbs with the 3 segments can be visualized. Counting the digits is not mandatory. Remember, first trimester anomaly scan has not replaced the second trimester scan, but when you do both of them together, you definitely increase your prenatal detection rate for anomalies. The benefits of early anatomic scan is early identification of abnormalities. You have the early option to be given to the patient for counseling, for genetic testing, refer them to a pediatric surgeon, and early option for termination of pregnancy. On the flip side, there are some unnatural natural history of some findings which you cannot explain to the patient. Early anatomic imaging of this type is a relatively new thing, and you have to work on it. You have to develop your skills. There's a learning curve. How the patient might react on findings in first trimester, whether she's willing to wait till the second trimester is another thing. Psychologically, it may impact the patient. Of course, in government sector, you have to see how much cost and resource allocation can be done towards this technique with the type of burden of patient load we have. Placental location in relation to cervix is noticed at this stage, but is not predictive at this stage. Please do not diagnose low-lying placenta and placenta previa in the first trimester. Always monitor the energy output. Keep your thermal index at the lowest ratio, which is given according to the ALARA principle, as low as reasonably achievable. As I told earlier, use an M mode to document cardiac activity, Doppler ultrasound only if clinically indicated, and limit the dwell time of the probe. You can improve your detection rate in first trimester scanning by regular education, training, teaching, timing the ultrasound, investing in a good machine, learn about markers, and follow protocol. The protocol has been given beautifully. These are the differences between the transabdominal scanning and TVS. Sometimes you have to use both of them in conjunction in order to have a satisfactory scan. Your detection rate of anomaly definitely increases as the gestational age advances. So OBGYN practitioners should be confident. First, start by doing simple obstetric scans and gradually enhance your skill. follow guidelines always, always. And important considerations are that the first trimester scan is not a substitute for second trimester anomaly scan, as more anomalies can be detected during second trimester. But high-risk pregnancies may have a higher detection rate for abnormalities in the first trimester. Always follow a structured protocol. These are very good images wherein the actual images have been compared with diagrams wherein you can improve your skills by reading. Always ultrasound first, learn to triage your patients into high risk and low risk, and then learn about further screening. The capacity to learn is a gift, the ability to learn is a skill, but the willingness to learn is a choice which all of us have. Thank you so much. Thank you, ma'am. I think you are the only person left, ma'am. Bela, ma'am.
Is it? Chairpersons are not there?
Anju ma'am
No,
is there.
Yeah. So much.
I'm here.
Brilliant talk, must say.
Yes, very nice talk, Dr. Monica.
Thank you, Anju. Thank you so much. I hope I could answer some of your questions, that how I gradually progressed.
Yeah, you can tell your story.
My story. All my story was in my slides. Welcome, Dr. Soma. How are you?
Hello. Fine. So will we move to the next session?
Yes, please.
Yes, ma'am. We'll move to the third session.
Purva, please. Yeah.
Now I request Nandini to proceed for the third session.
Thank you, ma'am. After a wonderful session on UST in early pregnancy, we move ahead with our third and final session by a very eminent speaker, Dr. Bela Bhatt Madam, on third trimester ultrasonography. To chair the session, I request our chairpersons, Dr. Kalpana Gulwade Madam, Dr. Anju Verma Madam, Dr. Somdutt Madam, and Dr. Kiran Chandna Madam. Can I have the CVs of Dr. Kalpana Gulwade Madam? Dr. Kalpana Gulwade Madam. Madam is currently the consultant at the Gulwade Hospital in Chandrapur. She is also the president of Chandrapur Obstetric Society. She has been organizing secretary at various national and international conferences.
Yeah, my
And she is
CV has already been read once, so I think we can skip it. Right?
Nandini,
If you want to.
choose respected Kalpana ma'am. You can proceed.
Yeah, sure. Please
yes,
proceed.
ma'am. Going ahead with Dr. Anju Verma Madam. Madam is currently the secretary at Gwalior Obstetric Society.
I think my CV is also read in the talk
No,
of
ma'am.
Dr. Sujit.
No, ma'am. Actually, we could not read your CV,
Yeah.
so apologies for that. If you allow, shall we?
Yeah. Please do.
Yes, ma'am. She's a consultant at Dr. Verma Hospital and Fertility Center. She is also the vice chairperson at MP Chapter SR, and she has she's been organizing secretary at MP SR 2023. Madam has credit to a various firsts in her life, such as first IVF baby, first ICSI baby, first egg donation baby in Gwalior Chambal division. We welcome you, ma'am. Our next chairperson. And its chairperson, Dr. Somdutt Madam. Madam is the joint secretary in FOGSI, for FOGSI 2026. She is also the consultant at Woodlands Hospital, Bhagirath Neosia Hospital, and Bellevue Clinic in Kolkata. Madam is known for her minimal access surgeries and high-risk pregnancy. Our last chairperson, Dr. Kiran Chandna Madam. Kiran Chandna Madam is director at the Chandna Medical Center, Faridabad. She is also the president of Faridabad Obstetric Society. She is the vice president of Faridabad Menopausal Society, and she has organized various national conferences, and she has various esteemed awards to her credit. We welcome you, ma'am. I request our chairperson to kindly introduce our speaker for today, Dr. Bela Bhatt Madam.
I don't think. Can I start?
Yes, Dr. Soma. So good to see you.
Yeah, yes. Dr. Bela Bhatt needs no introduction. But still, for formality, She is currently as the designate Vice President-elect of FOXI. And she is the first committee chairperson of fetal medicine of FOXI. She is the lead consultant of Dr. Baylor's Women Hospital at Fetal Medicine Center. And she is now the Joint Secretary of AFG Mumbai, Managing Council member of ISPA. She won the CS Don First Prize at AICOT in 2016, Bhubaneswar. And she has so many accolades added to her credential. So may I love her to start the session.
Thank you.
Madam, the floor is all yours.
Thank you so much, Dr. Soma, for those very kind words.
And those who don't know you, for those she's the dance queen of FOXI.
Thank you so much. Yeah, that's just a hobby. But thank you so much for so much of love that all friends always shower onto me. Thank you so much.
We have been enjoying your Garba reels.
Yeah, Navratri and Gujus are inseparable.
Now the fetus will dance with your two.
Yeah. So first of all, at the
over to you.
First, thank my dear friend Monica Singh for making me part of this. Now, about Monica, I would just like to say one thing, that she's not just brilliant in her work, she's a brilliant academician. What is very, very important is she has been consistently doing this synergy and other series of academics, and has been of a great help to all the OBGYN, in the field of ultrasound and infertility. And she has done so much of work. So hats off to you, Monica Singh, and your other half, Dr. Randhir Singh. Excuse me, Dr. Randhir Singh. So both of you have been doing wonderful work. So first of all, congratulations. And today I'm very glad that we had the blessings of President-elect 2027, Dr. Madhuri Patel and Dr. Rosa Ulai. So I'm very glad to be part of this wonderful webinar. And of course, my dear friend, Dr. Jayarani Kamraj as well. And to chair my session, I have my dear friends, Dr. Soma Datta. We have recently met, Dr. Anju, Dr. Kiran, and Dr. Kalpana. So it's my a proud privilege to be part of this webinar. Let me just take a second to share my presentation and make full screen. Okay, full screen, entire screen. Yeah. And before I start, Monica, once again, let me all the best wishes to you. I want to see you there in FOGSI as soon as possible. So all of us are full support and best wishes from core of our heart.
Thank you. Thank you so much, madam.
So yes, I think that was a old CV, but fine, that's fine. Okay. So the topic that Monica has given me is third trimester scan, right? We know prior to the final journey. Now, we all know that a lot has been, Monica has beautifully spoken about the first trimester. Dr. Sujit has mentioned about the second trimester anomalies. And by the time we reach 28 weeks, we feel that we have done everything. We have done a good early pregnancy scan, and we have done a good nuchal scan, and we have, seen that the patient is low risk for aneuploidy, and again second trimester scan, and we have seen that there are no structure anomalies. And now then what is left for third trimester? We are here to just have a look at the growth of the fetus and the liquor and placenta and cervix. That's it. Well, how much importance we give to first and second trimester? Third trimester scan is equally important, and taking things lightly must lead to big difficulties. So let's see what all we are supposed to look at in the third trimester, that is more than 28 weeks. Now, again, let me tell you, there are multiple dimensions to third trimester scans, starting from fetal viability, presentation, confirmation of dating, this biometry and growth, of course, the interval growth and growth charts, and diagnosis of late fetal growth restriction, diagnosis of large for gestational age, so all types of growth disorders, late onset structural anomalies we have not seen before, has evolved or detected late. And of course, placenta and Lichen service. And I'm very happy that Dr. Sujit has covered placenta, Lichen service, because I'm not going to talk about it in this talk. Because what I feel is you concentrate on few points, but do it well, understand it well, how to use it well in your daily practice, then you'll definitely be able to help patients. So I'm going to concentrate mainly on the dating thing, on the growth disorders, and some of the late evolving anomalies. Now, again, in the third trimester also, the question of dating comes. The fetus will ask how old I am. We know for sure that the dating is done best at first trimester scan between 8 to 10 weeks, or nuchal scan. We know the CRL is gold standard to date a pregnancy and assign EDD, because that forms the foundation to monitor the growth of the fetus throughout your second and third trimester. I know for sure. But do you get sometimes patients who present directly in the 7th and 8th month, do not have any kind of early pregnancy scans? Well, today also, sitting in Mumbai also, I still get such patients. Patients coming from periphery, patients coming from the government hospitals for referral. They may not have, many of them do not have any, it's a sad thing, we all know, but still, don't think that everywhere people are going for the first and second trimester. We are trying to invert our pyramid, but there are patients whom we first time encounter in the third trimester, where the LMP is not known, no scans are done. Then how do I date? That is the biggest question. So of course, we are going to do the biometry for the fetus. We'll start with our BPD, HC. We're going to take that. And we are also going to have a look at the abdominal circumference and femoral length, right? Now, what do I do if I do not have any ADD which is assigned? If I do not know the precise LMP of this patient, how am I going to date this pregnancy? So, well, in all such cases, what I'll do, if I have everything BPD, HC, SC, FL, then fine, I'm going to look at the size of the fetus based on that. What is most reliable is head circumference and femoral length. Both are bones. The measurements which are dependent on bones. So you can look at the HC plus FL if the patient comes for the first time, or if the FL is not available in the report, you can rely on the HC and date. This is a rough estimate, but still it will be 15 days plus or minus even at 32 weeks. So what I typically do in third trimester, now this particular patient came to me at 27 weeks, 4 days, no LMP known, no previous scans done. So what do I do? The gestational age cannot be ascertained as the patient is not sure of dates and no early pregnancy scan done. But the fetal size, what is the sonography going to give me? The BPD, HC, AC, FL is going to give me the fetal size today. So the fetal size, which is as per the scan done today, is of 27 weeks, 4 days, which the machine gives. And then I advise the patient to come again after 2 weeks. I'm going to reassess the size of the fetus. And if the fetus is growing at the same size, after 2 weeks, it shows a growth of 2 weeks, then I'll assign the EDD based on that. And that is my dating. This is the best possible way I can date a pregnancy, provided if I do not have any early pregnancy scan. Of course, if you have a good nuchal scan, which is done, early pregnancy scan, anomaly scan done, you have to date based on this scan. This is exceptional cases where we have to date only in the third trimester I'm talking about. So look at the size of the fetus, repeat scan after 2 to 4 weeks, look at the interval growth. If it is proper, then assign the EDD and then monitor the fetal growth from there on. Now, coming to the diagnosis of growth disorders. I have been telling this in my every talk that we must learn to talk in the languages of centiles and growth charts, right? Even if you have done your first trimester scan well, second trimester scan well, but if you have not looked at the centiles, if you do not chart those centiles on the growth chart, you will not be able to diagnose any small for gestational age, any fetal growth restriction, or any large for gestational age, because what we need to look at is the plotting of these measurements on growth chart to find out whether the fetus is too small or too big. And for that, we have to see that it is within 10th to 90th centile. And how do you come to know? Only if you look at the centiles. So even your machines will give you centiles. If you do not have softwares, fine. Your machine gives you centiles and also gives you growth chart. Develop a habit of having a look at the growth charts, plot those measurements. If you have done, suppose in this, you can see at anomaly scan, the growth of the fetus was on the 50th centile. And when I do the scan at 32 weeks, it has fallen at 5th centile, right? It is the EFW and the AC which is going to tell you whether the baby is growing well or not. And therefore, if these two centiles are falling below 10th centile, I know it is small for gestational age. And then I'll try and find out whether it is growth restricted fetus or not. But unless and until you put it on the chart, see, it's so easy for the obstetrician to understand. It's so easy for the patient to understand that the growth is, the fetus is not growing on the same centile. It is falling below what is on which centile the fetus should have grown. So it tells obviously that growth is not normal. Now, when it comes to the diagnosis of late onset fetal growth restriction, first let's talk about fetal growth restriction and then large for gestational age. So when you find that the either AC or if EFW is less than 3rd centile, you know for sure this is beyond 32 weeks. This is late onset fetal growth restriction. Or any two of the three following, either the AC or EFW falling below 10th centile, or ACFW crossing by 2 quartiles on growth centile. So what do I mean by crossing by 2 quartiles? If I'm looking at this, 1 quartile is equal to 25 centiles. So if the growth has fallen by 50 centiles, that means it has fallen by 2 quartiles. And that is also one of the criteria after 32 weeks to diagnose fetal growth restriction. And the third thing is based on the Doppler parameters. If your cerebroplacental ratio is less than 5th centile, or your umbilical artery PI is more than 95th centile, these are the criteria for diagnosis of late onset fetal growth restriction, for which you have to look at the multi-vessel Doppler, and based on that, you'll be able to diagnose. Now, when I talk about multi-vessel Doppler, it includes umbilical artery Doppler, middle cerebral artery Doppler, ductus venosus, and maternal uterine artery Doppler. Now, before we go into details of it, I will just share an example of a case because I think we learn a lot from the cases. So I'll just share here one case. This is 34 years old primee with conception after 14 years of infertility. Now, the patient was referred to me at 32 weeks, 5 days for a scan. Now, this patient was regularly taking antenatal care. Several ultrasounds have already been performed, and there was proper dating scan, which was also done at that is nuchal scan, which was done at 3 months. And based on which she was referred to me at 32 weeks, 5 days. Now, when I did the scan, I found that the growth was at 3rd centile. And because it was on lower side, I performed the Dopplers, but the umbilical artery, MCA, and the cerebroplacental ratio were normal. So I just put the diagnosis of late onset fetal growth restriction with the advice that because this is stage 1 FGR, we have to advise the patient for kick count and repeat the Doppler after 1 week. Unfortunately, after 1 week, I couldn't do the scan because I was not available. And the scan was again done by the same radiologist who had performed the previous scans. Now, how I wish it was one-to-one conversation between us, because I just wanted to know if any one of you still mention weeks on ultrasound corresponds with weeks of gestation. That was what was mentioned in this report, that weeks of ultrasound corresponds with the weeks of gestation and there is no brain sparing effect. Well, number one, gone are the days when we used to report weeks of ultrasound corresponds with the weeks of gestation. We must always mention about the centiles, whether it is growing on the same centile, what centile of growth, EFW, AC, etc. Anyways, this was the report which was given that the growth is okay. There is no brain sparing effect at 34 weeks. And then 3 days after this scan, patient comes with reduced fetal movement. The sister or the nursing staff tried to take the FHS, and maybe it heard some uterine shuffle or something, and which was very, very low. So the emergency C-section was done, but a stillbirth baby of 1.6 kg was born. Now, because I had scanned this patient once, and because I had also diagnosed it as late onset FGR, I was shocked to get this update. So I just wanted to know as to what went wrong and could we have prevented this IUFD. There is no blame game here at all. We must audit whenever we have anything untoward result. We must try and audit whether we could have done something. So I tried to look back, and there was a scan before me also at 28 weeks, which was reported as normal growth. Now, why I have been hammering repeatedly about looking at the centiles? Because 28-week scan, which was done by the radiologist, which reported the growth normal, I went and looked at the centiles. Look at this. The EFW is showing 3.3. This is EFW, 3.3 centile. Look at the AC, 5.3 centile. Machine, this is the machine report. But the growth was reported as normal because centiles were not looked at. Both the centiles were less than 10 centile. And what do? The minute the EFW and AC is less than 10 centile, next step should have been, the Doppler should have been done. But at 28 weeks, Dopplers were not done. So remember, again and again, I'll hammer, always look at centile. We cannot say the growth is normal unless and until we have had a look at the EFW and AC, right? So had we looked at these two centiles, we would have labeled as small for gestational age, and then we would have done the Doppler. But in this case, at 28 weeks, Doppler was not done. Patient came to me at 32 weeks, 5 days. I found that the growth is at 3rd centile. I looked at the umbilical. Diastolic flow is still good. MCA, still the PI was okay. Diastolic flow was less only. So MCA PI was high only. So Dopplers were normal at 32 weeks, 5 days. But it was stage 1 FGR. So Doppler was advised after 1 week. Instead of 1 week, the patient went after 9 days. At 34 weeks, the report of radiologists, which mentioned that the weeks on ultrasound correspond with the weeks of gestation, and there's no brain sparing effect, but these were the pictures. So I compared the ultrasound which was done at 32 weeks and which was done at 34 weeks. Now, this was the one in which I had reported normal umbilical. So if you just compare the changes in 9 days, umbilical artery Doppler was normal at 32 weeks, but 32 weeks, 4 days. But at 34 weeks, if you see, can you see grossly, the umbilical artery PI has gone beyond 95th centile. It had increased more than 95th centile. If you look at the MCA PI, you see at 32 weeks, 4 days, there is less diastolic flow. But look at 34 weeks, there is increased diastolic flow. That shows that there is brain sparing effect. The fetus is screaming and telling, I'm getting hypoxic. I'm trying to compensate by vasodilatation in the brain. And therefore, there is increased blood diastolic flow in MCA. And therefore, cerebroplacental ratio, when I calculated, it was less than 1 centile at 34 weeks. So it was obviously suggestive of brain sparing effect at 34 weeks. But it was reported as normal growth with no brain sparing. So what has gone wrong? We have not looked at the brain, the centiles. We have not looked at the changes that has occurred. What is more important than static things is look at the change in the umbilical and the MCA Dopplers. If you put together, you come to know, look at the increase in diastolic flow in the MCA, and therefore the CPR, which is very, very important in late onset fetal growth restriction, which was less than 1 centile. So ideally, the fetus was screaming and telling that I'm getting hypoxic. I'm trying to compensate for the hypoxia by vasodilatation, and my CPR is less than 1 centile. Ideally, we should have admitted at 34 weeks, daily do CTG or give steroid and deliver the baby. It was 34 weeks. We could have prevented this stillbirth. So, as I said, what is very, very important is to look at the trend, the Doppler trend, look at the CPR, look at the centiles. We forget to look at the centiles. If you do not look at the centiles, if we do not look at the CPR, we will miss the diagnosis of all late FGR. Even if the growth was fine, even if your nuchal scan was good, even if your anomaly scan was good, even if your growth was excellent till 28 weeks, in the third trimester, if we do not look at the centiles, if we do not look at the Dopplers, if we do not look at the Doppler trends also, after diagnosis of late FGR, we are going to miss the diagnosis as well as will not be able to give the proper result. We will not be able to monitor these fetal growth restrictions, because in early onset fetal growth restriction, you will find all umbilical artery abnormalities which may not be there in late onset fetal growth restriction. But CPR is extremely important because that will be abnormal. So whenever the CPR is less than 5th centile, it raises a red flag that you must do close monitoring with kick count, NST, BPP, and CTG. Because if we do not do all this in the third trimester, after your diagnosis of fetal growth, late onset fetal growth restriction, we will have these such surprises and we will have such stillbirths, because late onset fetal growth restriction is responsible for 40% of term stillbirths. The reason? Failure to diagnose late FGR, even after diagnosis, failure to monitor with all these parameters. Doppler may not. Your ductus venosus will be absolutely fine in third trimester, late FGR also. It's NST, BPP, and CTG which will tell you, because here it is the brainstem which is getting affected, and that you can pick up only with NST, BPP, and CTG in the late FGR. So it's very, very important, and then decide the triggers for delivery. So what are the triggers for delivery in late FGR? When your CTG shows reduced bit-to-bit variability less than 4 beats per minute, or there are spontaneous decelerations, or non-reactive NST, or abnormal BPP score less than 4. All these are pointers which tell you that at this point, the baby is hypoxic and you need to deliver the baby out, otherwise there'll be stillbirth. Now, when we have talked about early and late onset fetal growth restriction a lot, and we know that is severe hypoxia in early onset and there is mild hypoxia in late onset. But does that mean that it needs less intense monitoring? No. In fact, the thing is, the near-term fetuses have very reduced tolerance to hypoxemia because they have very high metabolic rate. So even small amount of hypoxia, they'll not be able to tolerate. That's the reason they develop the acidosis faster than the preterm FGRs, and therefore the chances of stillbirth is very, very high. So it's our duty. We have to be sensitized to looking at centiles, to looking at CPR, to picking up late FGR, to monitor them well with NST, BPP, CTG, and not let these fetuses go for stillbirth, right? So frequent monitoring of this pregnancy is warranted if you want to prevent the stillbirth, right? And therefore, it's very, very important that we do growth with Doppler at 32 and 36 weeks, because as I said, growth and Doppler will tell you about the centiles and the CPR and other values, and then you'll be able to pick up these late FGRs. As I said, out of all FGR, 70% are late FGR, and these are responsible for 40% of term stillbirth. So if we want to prevent that, we must pay attention to third trimester growth and Doppler. And knowledge is treasure, but becomes ignorance if we don't put into practice. After listening to so many talks also, if we do not have a habit of looking at centiles, if you're a sonologist, I still see so many reports without centiles. If your sonologist doesn't give you centile, please ask for centiles at every stage in pregnancy, be it your anomaly scan, be it your 28 weeks growth scan, be it your 32 week scan, be it your 36 weeks scan. Please do not accept any reports if there are no centiles. For everything, BPD, HC, ACFL, EFW, and if you are doing Dopplers, we need centiles for umbilical artery, for middle cerebral artery, for CPR, because without that, the diagnosis of FGR is not possible. If you cannot diagnose, how are we going to monitor and manage these babies with fetal growth restriction? So first thing is get sensitized, ask for the centiles, because then only we'll be able to help our patients. So that was about small for gestation and fetal growth restriction. Now, equally important in third trimester is also to diagnose the large for gestational age, because we know that because of the effect of the pregnancy hormones, between 24 to 28 weeks, this is the time after which there are many patients who are not diabetic or do not have gestational diabetes may develop gestational diabetes late, and therefore, how do we pick up these patients? Well, how much we are worried about small for gestational age? We are also worried about the large for gestational age. So when we are monitoring the growth, as I said, when we look at the centiles, the birth weight is crossing 90th centile, or your abdominal circumference is crossing 75th centile from 29 to 33 weeks of gestation, well, you must do a 75 gram glucose talent test. Even if you have done the 75 gram glucose talent test in the first or second trimester and it was normal and patient was not GDM, you must repeat it, because there are few 15 to 70% patients who develop LGA and are picked up by the third trimester 75 gram glucose test. So accelerated AC, FW more than 90th centile, and polyhydramnios, which has developed in the third trimester, are the red signals which tell us, look at the sugars, because this may be a patient who may have developed gestational diabetes mellitus. So that's a good way to keep a watch on the sugars as well. So having talked about the growth, the dating and the growth disorders in third trimester, remember, late second and third trimester scans are not just growth scans, because we know that your second trimester anomaly scan, we will be able to pick up 85 to 90% of anomalies, but not all anomalies, because there are going to be some anomalies which we are going to pick up in the late second and third trimester. And in that, the reason could be anything. The reason could be either it is late evolving anomalies, many of the CNS anomalies, many of the GI tract and renal anomalies, they evolve only in the third trimester, right? The CNS anomalies like microcephaly, some of the intracranial hemorrhages, some of the cysts, many of the anomalies you will find in the late second and third trimester anomalies, skeletal dysplasias, the lower urinary tract obstruction, luto, many of the GI tract atrasias, you will find only in late second and third trimesters, right? So whenever we are counseling also at the second trimester that I do not see any structural defect, we always counsel and tell the patient that, well, I can rule out 85 to 90% anomalies, but not even at second trimester anomaly scan, because the baby is growing. So typically I always tell the patient, it is like a 4-story or 3-storied building which is being built. So at first floor, you will be able to see only certain things. Second floor, you will see more things, and third floor, only when you reach that floor, you will be able to find certain things. Similarly, in the baby also in the third trimester, there are structures that are developing there. Anomalies which are evolving in the third trimester that you will see. There are certain anomalies which are there from the beginning, like the diaphragmatic hernia. The defect may be there and early in the pregnancy, but sometimes the herniation of the stomach or the intestine or the liver only occurs in the late second and third trimester. So you'll be able to pick them up late. It was there, but we cannot pick up early because herniation never happened. So this is how we are supposed to counsel the patient once we diagnose certain anomalies in the third trimester. So what am I going to do? Any scan is an anomaly scan. We know that now. Any growth scan is also an anomaly scan. So in late second and third trimester, when I am looking at the biometry, see, it doesn't need too much of an extra time. When I'm going to look at my BPD and HC, I'm also going to have a look at the ventricles. I'm also going to have to look at whether I can see a good CSP there. I'm also going to have a look at the thalamus and the cerebellum, which is there, right? So when I'm taking doing my routine biometry, I'm always going to have a look at all the intracranial structures, and I can screen for these CNS or the brain anomalies. When I go down, I have a look at the cardiac activity. I'm going to have a look at the 4-chamber view. I'm going to grossly put on the color Doppler, and I'll have a look at the inflows, outflows, 3-vessel trachea view. As I go down, I look at the abdominal circumference. I look at the stomach. I rule out any double bubble. I go down and I have a look at the axial scan of the kidneys. I go down, I look at the bladder, I look at the 3-vessel, whether 2 umbilical arteries are flanking it, and then I go down and look at the femur. So when you are doing your biometry itself, you can rule out many anomalies as you go from top to bottom, and you can see and you rule out anomalies. So it will need some extra time to have a look at all the structures. So screen for whether you have missed any anomaly. And as I said, because I know that GI and GU anomalies typically evolve in the second and third trimester, I'll have a look at the kidneys well, I'll have a look at the intestines well, I'll have a look at the diaphragm well, I'll have a look at the brain structures well, to see if there is anything which was not picked up earlier, which I'm seeing now. Now, I'll share 2 cases here of late evolving anomaly, so to get a better idea on this. So this was 30 years old, primary gravida. First trimester screen was low risk. Anomaly scan, which was done at 18 weeks, did not show any gross anomaly. Now again, 18 weeks anomaly scan was done by a trained sonologist in a standard manner, which did not show any anomaly. Patient presented to me at 26 weeks, and this is what I see, right? Can you see the double bubble here, right? So when I see a double bubble, and when I can see a connection between the 2 bubbles also, I know that this is a duodenal atresia, and it is one of the evolving anomalies. Now, because duodenal atresia is also one of the marker for Down syndrome, the patient was counseled that we must do amniocentesis to rule out Down syndrome. And in this particular patient, it did turn out to be Down syndrome, which was diagnosed at 26 weeks. Now, we all know that the minute we counsel the patient that this is the anomaly which I see now, the first question patient will ask is, Madam, was it missed when my anomaly scan was done? Because I was told that the baby is fine at 18 weeks, anomaly scan was done. So our answer should be no. The sonologist is the best job, and sonologist has not missed anything. But because in duodenal atresia, it may so happen that in some of the cases, the duodenum, the fluid will take time to get collected in duodenum, so that a double bubble will appear only late. And therefore, in some cases of double duodenal atresia, it is not possible to pick it up at 18 weeks. And there was a picture also which was given to the patient at 18 weeks, which showed a single stomach bubble at 18 weeks. So it was done diligently, it was done properly, but because it was evolving anomaly, we can pick up only late. And therefore, this counseling is extremely important, because today it's you, tomorrow it can be, your patient going to somebody else, and we should never ever say, and in this case, we know for sure that absolutely there was no mistake on the part of sonologists, but because it's evolving anomaly, it's not possible to pick up at 18 weeks, and the double bubble appeared late. But then fortunately we are in India, the law has amended, so the patient went to the board, got the permission, and got it terminated because they did not want to continue with Down syndrome baby. So the most important message here is counseling in such late evolving anomalies. Now, this is second gravida, first female, which was normal, non-consanguineous marriage, spontaneous conception, came at 28 weeks, 4 days. Now, again, patient was taking ANC from a government hospital, a very poor patient, and was referred for polyhydramnios to me to have a look at the structures of the fetus. Now, at 28 weeks, 4 days, when I did the scan, there was, yes, of course, there was polyhydramnios, but as you can see in this clip, this is, you can see the portal vein sinus here, but you cannot see the stomach bubble here. It was persistently absent, and I made the patient sit outside for some time, took it inside, again after half an hour, 1 hour, but there was no stomach bubble which was seen with polyhydramnios. So the first suspicion is always a structural defect, which is either esophageal atresia or tracheoesophageal fistula, right? That is the first suspicion when you do not see. But after some time, when I called the patient, I couldn't see any blind pouch in the neck. I tried to look for it, but again, we know that tracheoesophageal fistula has a very low antenatal detection rate. So we cannot pick up all the tracheoesophageal fistula antenatally. And so we have to mention that when we report such cases. After a long time, I could see stomach bubble, a small stomach bubble, which again disappeared in some time. But I had a suspicion of TO fistula. There was also mild hydronephrosis or pylectasis, which was there. Now, another positive finding in this patient, the growth was at 3rd centile. After correct dating, the growth was at 3rd centile. There was fetal growth restriction. Remember, fetal growth restriction can also be one of the markers for sometimes genetic or chromosomal disorders. So here I had two suspicions. One, of course, either TO esophageal atresia or TO fistula. And second, maybe some genetic cause, right? So patient was counseled for amniocentesis and testing, but patient went back to the government hospital with the report where they didn't agree for the amniocentesis, and they continued monitoring, and patient delivered at 39 weeks, a female of 2.5 kg. Now, based on these ultrasound findings, pediatrician also suspected, and they tried to rule out the esophageal atresia first. They passed the infant feeding tube, and on auscultation, there were air bubbles. So they first ruled out the esophageal atresia or tracheoesophageal fistula. The structure anomaly was out. But what additional finding they found was that there was some neurological abnormality. There was axial hypotonia. And so they suspected Prader-Willi syndrome, which is a genetic syndrome. Now, because baby had hypotonia and also had swallowing difficulty, they were trying to feed the baby, but baby had difficulty in swallowing, and there was frothing from mouth at birth and weak swallowing and poor sucking. So I tried to join the dots, antenatal and postnatal findings. Antenatally, what were our findings? Absent stomach bubble or a small, very small, intermittently appearing stomach bubble. There was polyhydramnios, and there was early fetal growth restriction. And on birth, baby had poor sucking, poor weak swallowing, and frothing at mouth. So we know now that because baby was even intrauterine, we all know that baby drinks the same fluid and urinates, and that's how the amniotic fluid is the balance of the cycle of the amniotic formation and drinking goes on. So because the baby uterine also had a poor sucking, because of the genetic syndrome, baby was not able to suck, and therefore there was polyhydramnios, and therefore the stomach bubble was absent for most of the time. right? So now we can connect the dots. And the pediatrician, they counseled the patient. The blood was taken for the genetic syndrome, that is Prader-Willi syndrome. Typically, that report takes 4 to 6 weeks time to get the results from the genetic lab. Patient was kept in the NICU for a month, but the relatives realized that this is some genetic syndrome and the baby was not improving in hospital. So they took DAMA, and then at 1 month age, and then the baby died after 4 days at home. Now, what is important here to learn from this case is this was one of the evolving anomalies, we can say, because the stomach was absent and there was polyhydramnios. I was suspecting some structural defects. Sometimes we suspect that there is structural defect, but that can be like a chameleon. There can be different, some other condition may come up. So here we had a very strong suspicion of a structural defect which is causing absent stomach bubble, but there was some genetic cause, Prader-Willi syndrome, which was leading to all this. So what is very important here is that patient was counseled that, there is some, there can be either some structural or genetic cause which can lead to all these findings. So they were mentally prepared. And postnatally also the assessment was done, and the samples were taken and diagnosis was made. But they were mentally prepared for some kind of abnormalities of fetus. And working upon the case is important because it will have bearing on the next pregnancy, and depending upon whether it's autosomal recessive or autosomal dominant condition, it will guide them and will help them in next pregnancy. At 3 months after a nuchal scan, a CVS can be done for the same genetic mutation, and they can find out whether the fetus is affected or not. So that's what is very, very important. And the only thing that I wanted to stress here is that at every point in time, whether it's your nuchal scan, whether it's your anomaly scan, whether it's late evolving anomaly, counseling of the patient is extremely, extremely important. And also tell the limitations. As I said, it's not always possible to diagnose a TO fistula antenatally. So that is also to be put in to the patient, that it does not every anomaly has 100% detection rate, and there are always limitations. So I typically tell every patient, whether you do all the scans, you get all the tests done, still 100% is always at birth, and not even at birth. When the baby develops 6 months, 1 year, 2 years, there are some of the neurological, some of the rare mutations which may give rise to some neurological disorders, which we do not come to know even at birth, right? So never ever counsel the patient that all tests are fine, so baby is going to be fine. There are limitations. There are humanly limitations. There are limitations of the test. There are limitations of the ultrasounds, which always has to be counseled to the patient. This is the last case. Second gravida, first male was normal, spontaneous conception, non-consanguineous marriage. Again, the anomaly scan, which was done well in a standard manner at 19 weeks, didn't show any anomaly. Patient presented to me at 29 weeks. And at 29 weeks, what I could see was, as you can see, there is a echogenic small locus, which is seen in between in the spine, right? Which is here also in the image also you can see. So this is typically because either of the fibrosis or because of the calcification in the spinal cord, which is known as diastematomyelia, which was seen at 29 weeks for the first time. Now, the minute you tell that there's something wrong with the spinal cord, the patient is going to be very, very much afraid that there'll be something wrong with my baby's spine, and what will happen to the the lower limb activities, etc., etc., etc. Now, in this particular case, there was no meningocele, no meningomyelocele, no tethered spinal cord along with this. So patient was counseled that generally isolated diastematomyelia has good prognosis. But what we do is, whenever we find antenatally any abnormality of any system, it's always better to send the patient for counseling with that particular system specialist. So this particular patient was sent to a pediatric surgeon for getting opinion on the postnatal outcomes of isolated diastromatomyelia. Patient went, and again the pediatric surgeon also counseled that isolated diastromatomyelia, when there is no associated meningomyelocele, has very good outcome, and they can always continue with the pregnancy. And they continued with the pregnancy, delivered with me a female of 2.7 kg. Now, this is the postnatal ultrasound which was done, which also confirmed there was a bony spur, that is diastromatomyelia, which is seen in the mid-dorsal region. And the baby was followed up and is now 4 years old. As you can see, is walking very well. There was no intervention done in this particular patient. No surgery required, no intervention done. So where need be, we should always do positive counseling, because patient may want to come in looking at any kind of spinal anomaly. So it's important that we take opinion from a specialist, counsel the patient proper, look at the natural history and the outcome from the specialist in the postnatal period, and then counsel. And this is how the patient was counseled and the outcome was good. So as I said, the third trimester scan beyond 28 weeks, there are several dimensions. It's equally important at every stage. So, when we talk about the inverted pyramid of antenatal care, Dr. Prashant mentions that it should be a cylindrical care, right? Because throughout pregnancy, whether it's first trimester, whether it's second trimester, whether it's third trimester, equal importance is given. There are different kind of information which is coming out from each trimester. So in third trimester as well, we should have look at the fetal viability, presentation. Of course, presentation is very, very important, close to the term, whether it's breech, whether it's transverse, we all know that. And I already discussed about those women who didn't have any kind of scans done in first and second trimester. Dating is also important. We look at the growth disorders. We look at the growth late evolving anomalies or late picked up anomalies. Of course, we have to look at the location of placenta, placenta previa, placenta accreta spectrum, that thankfully Dr. Sujit has beautifully covered. We always look at the Liker, again, oligo, polyhydramnios, everything has been covered by Dr. Sujit, because otherwise I thought I have to take a separate talk, because a lot to talk about placenta, Liker, cervix also. So I think we have understood the important aspects of even the third trimester scan. And so if we give the equal importance to the first trimester scan, the second trimester scan, and all the aspects and dimension of third trimester, then we'll be able to give a good outcome for our pregnancy. And I'm sure every obstetrician, their ultimate goal is to have a healthy baby in the hands of healthy mother. And even if there is something wrong with the baby, we are here to try and help them as much as possible. Refer when necessary to a tertiary center, so that the baby can be taken care of, so that both mother and baby are safe and sound. So with this, I would like to conclude my talk. Thank you so much for patient hearing. Dr. Monica, I'll just share here. Just wanted to tell you that I specifically didn't touch the placenta cervix Liker, because I thought we can talk extensively on the same in some other talk. Thank you so much.
Madam, we are speechless, with your passion, your diagnosis, the amount of hard work, and that what you say, the minute precision with which you work, and especially the Prader-Willi case, madam. Just with the swallowing abnormalities of the fetus, you could correlate the polyhydramnios with the small stomach bubble. And, this is very encouraging to all of us, ma'am, who see you working. And thank you so much. Dr. Soma, are you there? Kiran, madam? Anju, would you like to comment?
Excellent talk, Dr. Bela, and mesmerizing. And you have completed all the aspects, and you have given the case-based discussion. And you have really enlightened us about the importance of centile growth, and also the color Doppler, also importance of color Doppler, and even the minute things that should not be ignored. If need be, we should go to, consult the specialist also. And the cylindrical care is very, very important, as you said. All the trimesters, they are very, very important when we do the scanning, because sometimes we may have missed the certain anomaly. We can pick up in the third trimester also. And the color Doppler is very, very important to avoid these triples. Thank you very much. Thank you.
So, madam, there is no inverted pyramid and there is no straight pyramid. It's a cylindrical care.
So there is inverted
Yes.
pyramid for sure, because we are trying to predict the things and prevent. So it has its own importance. But what is important by cylindrical we mean is we should not then forget about the second and third trimester. It's equally important. So it's not that, as I said, second trimester सब ठीक है, so now just look at the growth and then baby will be fine. No, we know there's so many things which come up even in the second half of pregnancy, right? That's the reason at every stage we have to be equally vigilant.
Madam, another question I had was that these machines, I saw that your reporting was with Voluson, ma'am.
Yeah.
Yeah. So we also, most of us are working with Voluson machines and GE machines. So, ma'am, when the report is given in the GE machine of antenatal patient, they give you the centiles.
Yes.
So that is enough, madam, or should you go for some costly software like Astraya and all that?
So there are good softwares for sure. So if you are doing dedicated fetal medicine work, yes, one of the softwares you have to use. So what I have been using is the one given by Dr. S. Suresh, SonoCare.
Yes.
It's a software which also helps you a lot. But even if you do not have any software, your machine will give you growth charts. And you can always monitor based on the centiles which are plotted on that chart. And at least you can come to know. Suppose that anomaly scan, my baby was growing at 35th centile. If it continues to grow on the same centile in your machine also, you know that the baby is growing well. If it falls from that, you know that it is falling.
Yeah.
So there is no need of some very expensive softwares. You can monitor the growth very well. Wherever you are, in whichever, even you have some higher-end machine, the remotest area, they may not have a higher-end machine. But every machine gives the growth chart. So you can always monitor the growth well.
And finally, it is the mind, the eyes can see only what the mind knows. So unless we know it, we will not be able to see it. And if we don't see it, we'll not be able to report it. So everything is, ma'am, like laparoscopy, endoscopy, everything is didactic. But I feel fetal medicine and ultrasound is something you have to be patient enough. It's a moving.
Just one thing about the growth centiles, why I keep on hammering, because daily I get so many referrals in which previous 3 scans and not a single scan mentions about the centiles. And that will very easily, we will miss both early as well as late FGR. Because if I don't have centiles, how do I diagnose FGR?
Yes.
And it's so important. It's so simple to put it, into centiles. But somehow that habit, so that's the reason, to remind every time that, you please look at the centiles and remind to the obstetrician if you're not doing, demand for the centiles from the sonologist.
I think, madam, most of the sonologists not giving this centiles. They just fetal weight, estimated fetal weight.
In Mumbai also, I'm getting such reports. Most of the, so without that, unfortunately, yesterday only I got a patient at 36 weeks. And directly when I'm doing scan, it is stage 4 FGR, reversal of diastolic flow in umbilical, reversal of A wave in diastolic, in ductus venosus, and the cardiomegaly because of FGR and hypoxia. Baby was about to die in few hours. I sent this for immediate C-section. Baby is on ventilator. They did C-section, severe FGR. It was early FGR, but previous scans never mentioned about any centiles. So diagnosis of FGR was completely missed. So if you do not put into centiles, you'll miss the diagnosis of FGR. When they came to me, by then it was too late. Too late. They didn't have any time to give steroids also. Immediate section because stage 4. DV A wave reversal is an ominous sign. We know already a lot of damage has happened. We don't know how it's not just the live baby which is important. Intact survival is important. The neurologically, I don't know how much the baby will be good because it's going to be bad. I know that. So that's the reason if we have a habit of looking at the centiles and growth charts, we'll definitely pick them up earlier. Had this baby been picked up earlier for early FGR, by 34 weeks, we could have given steroid and delivered and saved this baby. There was no need to wait till stage 4 FGR. So that's important. That's what is important.
Very nice, madam. Very nice take home message.
Thanks.
So, madam, you have been teaching volumes in your chairpersonship of imaging and fetal imaging committee. And that I think this will carry forward. Your passion is ultrasound, and surely in your vice president here, we will see lots and lots of teaching, widespread traveling, lots of physical CMEs, orations and keynotes. Thank you, ma'am, and hats off to you, madam. Thank you we have built the whole webinar around you, madam. So you are
all the 2 talks were also brilliant.
Thank you so much. I know how busy you are. Still, you have given this time pre-Diwali. Thank you, Anju, so much. Thank you, Dr. Soma, Kiran, madam, and Dr. Vishal, support team, Nandini, Purva, everyone who could join today. And, enjoy the academic session. And now we can full blast go to our celebrations after studying so much.
Yes. Yeah, hi, Dr. Soma. Good to have you.
Thank you. Thank you so much. Thank you so much for joining in.
Best wishes, Dr. Monica.
Thank you. I'm a long time away from election. I'm just working.
But still.
So thank you so much.
Meet you all in AICOG.
Yes.
Your consistent working will be very fruitful.
Thank you, Kiran ma'am. Thank you. Good night. Good night, everyone.
Bye. Good night.
From Synergy Club, Academic Club, I say goodbye to everyone. I wish a happy Diwali to all my friends, seniors, colleagues, and our tech team, and to our dear Dr. Vishal also, and his family also. And we will announce the date of the November webinar very soon, according to your convenience. Till then, it's a bye and best wishes from all of us. Bye, madam.
Bye. Thank you, dear, and all the best.